Okay, good morning, everybody. If I can get your attention for just a minute. My name is Maham, and I wanted to just let you know that the QR code for the pretest is up. Many of you have already completed this, and thank you for doing that. But if you have not, we have until 8:30 to go ahead and scan the QR code and take the test. If you don't mind going ahead and starting that. Thank you. Boom. Okay, now it's on. Good morning, everyone who just walked in. Hi, yes, I'm the voice from above. There are refreshments in the back. There's coffee, and there's a water fountain as well. You have your water bottles. Feel free to, get some refreshments, and we'll go ahead and start in about 15 minutes.
Yeah,
I was so confused. I was looking everywhere.
I didn't want to interrupt you.
Oh, thank you so much.
So,
I was like, I thought I was going crazy, to be honest. You found the other mic.
Yay, okay, perfect.
Thank you.
yep. And it's best to leave them on if you can,
Yeah, I
because
have this like bad habit of like turning them on.
I can lock them out so
Yeah.
you don't accidentally.
Yeah, that would be great. I don't trust myself.
Okay.
It's just like habit, you know?
Right. Yeah, because what happens is.
Do they have like endless battery?
No, they don't have an endless battery,
Yeah.
but there's plenty for.
Replacements?
Yeah. And but what happens sometimes when you turn them on and off, it gets a little wonky with the receiver picking them up. Okay, so no matter what you do with the switch.
Yay! Thank
Okay.
you. Love it.
Okay. I'll be right back.
Okay.
said next door.
Yeah.
Speaker. Yeah, it's like right next door.
We're in the BEC and ask if we're getting lunch or not.
Yes.
I will come.
Yeah, I know, right? It's amazing. You can just use them for whatever. Who's running it next year?
Do you want to?
I can. I've been there for 3 years.
I'll be your support.
Yeah, that sounds good.
Naz.
Let's do it.
Yeah.
I love it. Okay, cool.
Because I don't want to be in charge of this.
Yeah, it seems pretty intense.
It's the main thing is like, you know how many people dropped out last second?
No. Wait, all 30 aren't coming anymore?
No. I'm not talking about participants. I'm talking about facilitators.
No.
I had to change to facilitators like 7 times in the last 3 weeks.
Who dropped? Wait, do you need someone? Because I've done it. No? Okay.
Because we got Shama last minute. We got
Oh, she's right there, yeah.
2 people from. It actually ended up being a blessing because
They're really expert people. Yeah.
not only that, but Missy from
The other country,
Belize,
right? Yeah.
and Mary Guitar from Kenya are coming, so
Nice.
it actually is going to be a lot more
Amazing.
enriching.
I love that.
So it
You're
ended
gonna
up being a
highlight.
blessing,
Yeah.
but regardless, it was stressful.
Yeah, that sounds insane. Yeah. No, I remember. I mean, I was there when Naz did it, then I was there when Alicia did it, and every single time they were both like so stressed out. Yeah, it's a very stressful job.
I mean, I'm okay. I think it was more stressful the last couple weeks because I was also doing finals. I was also doing the ATRIC course in Boston. Like, I was doing everything at once. It was just the juggling.
Is the ATRIC course like nice? I feel like it's nice, right?
It was amazing. I went up to Sean and I was like, I don't even know how to like express my gratitude. Like, it's like really well thought out,
Yeah.
really well functioning. I told him that I want to be involved next year.
Yeah. As a person, yeah.
Yeah.
Yeah, I didn't want to do it because I wanted to take it at some point. And I heard that if you want to take it, you should not be a
You
person.
definitely should take it.
Yeah.
It's a part of this fellowship, so you'll be
Yeah.
taking it.
Okay, awesome.
Yeah. We'll cover it. And it's amazing. I loved it.
Yeah, I'm excited.
You will very much enjoy it. It is very stressful, like physically stressful, emotionally stressful, because the simulation is really true to life. Like, I mean, I'm not gonna lie to you. It took me a day or 2 to decompress afterwards, just to be like, okay, that wasn't real. That wasn't real. That wasn't
Oh,
real.
wow.
That wasn't real. I'm not gonna
Okay.
tell you anything more. I'm just
Yeah.
gonna say like, be prepared. You know.
I've heard that from other people.
Yeah.
Yeah. That's why I also didn't want to, like, everyone was like, do you want to come?
They said they don't know, but they texted Holly.
They texted Holly to ask. Okay.
All right, do they want you to come back, or are they going to come and tell us the
They
answer?
said to come back, yeah.
Come back, okay.
Okay.
Do you want to go back at like 8:40? Is that okay? That gives it so that
That way.
you have time between the people.
Yeah.
Yeah.
If we have an hour for lunch.
Do you have Holly's number?
Okay.
Can you text her?
If we only have 30 minutes for lunch, we might have to stretch that out.
Yeah, I think we will. I think last year we ate
And
an hour.
you know what? We're gonna have to stretch that out and maybe take out a break because if we go to lunch, they're not gonna be able to do all.
Well, this break isn't even 5 minutes. There is no break.
This is why details matter. All right, can you take that out?
Yeah.
It's
like
non-existent.
nothing. It's
You
non-existent.
just take the row out.
I mean, maybe if we finish other stuff quickly.
Yeah, I think we'll be fine.
I think we'll be fine. Even 30
We
minutes.
typically.
Yeah. Like, I don't think the water bottle. We're in time. Yeah, we're in time. Yeah, thank you. All right.
Okay, good morning, everybody. Good morning. Thank you so much for being here. My name is Maham Munawar, and I am a Global Health Fellow at the University of Pennsylvania. And I also have had the honor of being the chair and coordinator for this course. I really appreciate you all for coming and participating. And I hope this is a fruitful event for you. I hope you learn something and you all go out to be great trainers as well. So without further ado, I'm going to call upon Dr. Joy Mackey, who is from Baylor College of Medicine in Houston, and she performs the BEC in Belize. If you can all give her a hand.
Hello. Let me see if this guy works. Maybe. Okay. All right. So my name is Joy Mackey. I am Emergency Medicine Associate Professor at Baylor College of Medicine. I am in charge of our global section. And I have been teaching BEC basically since it was launched to the public in like 2018, 2019. So I'm very excited to be here and train you all as trainers. This is kind of my favorite part of doing the course because the course itself can be a little bit of a slog, but doing like the one-day training of trainers and talking about sort of the theory and why we're teaching this and how to teach it, to me, that's fun. So thank you all for being here and participating. So the BEC course, for those of you that don't know, is a 4 to 5 day course. It's a short course that's basically designed to provide principles for emergency care in resource-limited settings, right? So generally, you're teaching a mixed group of nurses, physicians, maybe some EMS personnel, and it's designed to provide sort of those initial skills that you need to manage emergencies. You can go to the next slide. In terms of background, I think this is important to think about when you think about the course itself. So it was developed over a long process. About 4 years, 40 plus countries were involved in sort of the consensus process to develop the course itself. It was developed as part of the World Health Organization and the International Committee for the Red Cross, and then it's endorsed or sponsored by the International Federation for Emergency Medicine, which is the one that manages the course. We'll talk about that a little bit later. Oh, thank you. It was piloted originally in 3 countries, and since it was piloted, it's been rolled out in many other countries, both in English and in Spanish. Every aspect of the course is really sort of brought together through a collaboration when it was originally designed, and was designed to be applicable in lots of different settings. So when you're teaching the course, you need to think about your context, because in some settings, some of what's taught in the course might be very, very basic, and you might want to elevate it a little bit. And in other settings, you might need to spend a little bit more time on concepts, depending on where you are. In terms of aims, there's 3 main aims for the course. The first is very similar to anyone who's done like ATLS, but it's ABCDE. So everything in this course is going to be repetitive, and it's going to focus on ABCDE. When you first look at the slides, when you're teaching this course, you will wonder why it is so repetitive, and it will feel very boring. But if you're teaching it and you're teaching it properly, the ABCDE is meant to sort of ingrain that so that by the time a participant is done with the course, they have that ingrained in terms of how they're going to practice. And as I said before, it's really about identifying and knowing how to treat life-threatening emergencies, either trauma or illnesses in pediatrics and kids. The other thing the BEC identifies is when to call for help and when to transfer, which is not necessarily something that is touched on deeply in other type courses. And so it really focuses on knowing your resources and being able to think about the system as a whole. So in terms of participants, when you're designing a course and thinking about who your participants will be, obviously you want to work with your institution or Ministry of Health or sponsoring organization, and it's going to be an interdisciplinary team. So your nurses, your physicians, ambulance drivers. The key with this is that it should be people that regularly work in an emergency setting at a facility or in an ambulance. So some of the skills that you're teaching are not going to be appropriate for a rural health worker in the middle of a village in Zimbabwe, right? They're not going to have access to the medications and the skills that we talk about in the course. And I think one of the big takeaways from teaching this course a lot is that it's important to have that interdisciplinary team, because communication and language is like one of the biggest improvements that we continually receive feedback from participants in terms of everyone being on the same page, everyone having the same approach to emergencies. So as I said before, context is really going to be key. So you want to take the course and think about the context that you're going to be teaching it and modifying it as needed. You never want to take anything out of the BEC materials, but you can add things in, slow things down, depending on how it goes. And honestly, I've been teaching this like 5 years in Belize. Every time it's a little different, and you modify it a different way. All right, any questions on background before I move into course structure? Okay. All right, so the structure itself, it's composed of 5 different modules. All of the modules have a component of the ABCD approach in them, and you will start off the course with the ABCDE lecture, okay? Trauma kind of covers everything because it involves elements of altered mental status and shock, difficulty in breathing, but then you also have specific modules that are pulled out for these. It's going to be composed of lectures. It is also going to be composed of small groups. You have skills. And then you also have these interactive large group discussions on medications and handover transfer. Generally, it's conducted over 5 days. Depending on your learners, you might need more or you might need less. Generally, it's conducted all at once, but you can also play with your timings. So for instance, I've done 2 and 2. So 2 days 1 week, 2 days the other the next week. We've played with the idea of like 1, 1, 1, 1, so like every Friday for a month. Or you can do all 4 days at once. It kind of depends on your constraints in terms of staffing and facility. The 2 things that I wanted to point out, so these don't make a big footprint in the manual, and so they're easy to skip over, but it's important to keep these in the course itself. This is the medication lecture and the handover transfer lecture. In particular, the handover transfer lecture should be done early. Like I would probably do that like after your ABCDE, because that's gonna give everyone the same format for how to do handover, which typically is the biggest stumbling block, especially with healthcare providers that are not used to doing handover. And you're gonna be utilizing that throughout all of your small groups. The medication lecture we tend to do at the end and make it into like a Jeopardy, so it ends up being like a review of all the meds that you talk about during the case. In terms of tools, there's the participant workbook, obviously, and we'll go through what's in those workbooks. There's skills instructions and assessments, and then there's quick cards in the back of the workbook. Did everyone get an electronic copy of the manual? Okay, and you've gone through it, so you're relatively familiar? Okay. This is an overview of the structure of the different chapters. So as you can see, each one will sort of go through the specific topic in like an ABCD approach and talk about management. There's pediatric considerations, etc. So this is an example of Module 2, so this is trauma. So it will always start with your objectives and your essential skills that they should learn after doing that module. Participants are expected to be filling out their books, if possible, if they don't need to reuse them. If they need to reuse them, they should still be answering the questions, but they can do it separately. But there's going to be key terms that should be filled out. They can find the answers for this in the glossary at the back. There's also going to be workbook questions that should be filled out ahead of time. And then there's also the case scenarios. So this can be a little confusing. So for facilitators, you'll have a facilitator manual that will have the answers to the case scenarios, but you have to like scroll through all of the lecture first. So what I recommend is actually creating a separate PDF of the manual where you just put all of the case scenarios together, and then you can go through them as you're doing your case scenarios. And then there's also multiple choice questions in the back as well. So all of that should be filled out by the participants, ideally prior to doing the small group for that part of the course. The skills assessments are also in the participants' manuals, and so when you're teaching them skills and then checking them off on skills, you will check them off in their manuals. And then there's also these quick cards, or sort of giving prompts and then giving a summary of what you should do based on specific situations. And that includes the critical actions. Okay, so that's what the participants have. And then in addition to that, obviously you all will have the course slides, and then there's also the facilitator manual. So that's sort of the basic bundle. And then on top of that, from there, you're gonna move on to sort of the more logistics or documentation phase. So in order to complete the course, participants have to attend, right? They have to do a pretest. In general, for the pretest, if you can have them do it ahead of time, that is ideal. I will say that I have never held a course where they have all completed the pretest ahead of time. So generally, I will send out the link, but then if they don't fill it out ahead of time, we just give time during the course itself to do it. Ideally, you want them to get their manuals at least a couple of weeks ahead of time as well. Obviously, you want them to attend all sessions, so you have a sign-in sheet. They need to complete all the workbook sessions. So generally, as we're doing the small groups, we'll go through and check them off on their workbook sections as well. They're going to complete all their skills. They need to successfully manage at least one case scenario in small groups. And then they need to take the final exam and pass with a score of 75% or greater. Sometimes you will run into language issues. So, for instance, I've had participants that are doing really well during the course, but then when it comes to taking the final exam, they don't hit 75%. I think it's always worthwhile to check in and see if it's a language issue, and so you can have them retake. Generally, there should be hopefully someone in your group that is bilingual that can help them. Any questions on what you need to do to complete the course? Yes? So the question was if the exam is only presented in English. There is an English version and a Spanish version. I don't know if anyone taught who's teaching anywhere else. Do you have it in other languages?
Yes, so in Pakistan we're working on, I have one, thank you so much. So I teach in Pakistan and we're working on converting it into Urdu as well. And so it just really depends on what region you're in and what resources you have and what local champions you have to be able to help you resource that.
Yes.
Sorry, and then I know you said you sent out the link to the pre-test. Is the post-test also online, or is this something you're normally printing out?
So it depends on your situation. I think the way the resources are given to you for BEC is if for both the pre and the post to be printed out. I found that was an easy way to lose a lot of information. And so we converted to actually like a Google Forms that we send out links to pre and post, and that way the data is already collated and scored for me. So, but I did that myself for Belize, so. This is an example of what the test looks like. So when it's in paper form, and then it's easy enough to sort of transcribe it into like a Google form as well, obviously. In terms of the course schedule, so this is an example of what it would look like if it were drawn out over 5 days. As I said, depending on your group, like for us, we tend to do this in 4 days. Other times, people will need to do it over a longer period of time, like 6 days. It really just depends on your learners and how much time they need. But you'll have example schedules in the facilitator guide, and then as you teach the course, you can play with time and kind of figure out what works best for you. All right, so we've talked about what you need to pass the course. And then in terms of documentation, you also obviously need to keep track of the participant's name. You want to keep track of their like pre and post test scores and what they've completed for BEC. And then ideally you would have that information kept with your local authority, be that the local facility that's sponsoring the course, the Ministry of Health, or whatever underlying regional organization is sponsoring the BEC course. In terms of the certification process, I want to spend a little bit of time on here because I think there's been some confusion on this in the past. So ideally, you will have taken the BEC course first. I don't know, I remember last year there was confusion as to whether or not our participants needed to take a BEC course. Has that changed?
So it has, and we'll explain that at the end.
Okay. If once you have taken the BEC course, then you are eligible to take a training of trainer course like this. One thing to keep in mind is not everyone that's taken a BEC course should be a facilitator, right? You want to pick out people that are good with public speaking, that are organized. So for instance, what we will often do is we'll teach a couple of courses in country and identify people that we think will be good trainers, and then invite them to do a separate training of trainers. So once you have a BEC trained provider, you can then take the TOT. Once you've taken the TOT, you're considered a provisional facilitator. As a provisional facilitator, you can teach with a master facilitator. And so if there are no master facilitators where you are teaching, I think IFM has a list of master facilitators, and you can draw on people and resources to come and help you with your course. Once you have taught one course as a provisional with a master, you are then a registered facilitator. You can now teach courses on your own, And once you've done 2 courses, you're then considered a master, and you can do TOTs on your own. Is that clear as mud? Okay. Any questions on that process? Okay. Again, the sponsoring organization is going to keep track of all this data, and then you also will need to update. Like if you're the person that's organizing for your country, you're also going to need to keep track of your facilitators and how many times they've taught, so that you can also update their certificates, right? Because they're going to be moving from provisional to registered to masters. And I should also say that just because you've taught 2 courses doesn't automatically make you a master. Like, we have some folks in country that have taught like 4 or 5 courses, but when I see them teach, I still don't know that they've entirely mastered the skills, and so I will keep them as a registered. I'm not gonna bring them up to master until I think that they're at that level. Okay. Overall, even though this is a WHO course, it's actually supervised by IFEM. And then IFEM basically would like you to register your course with the appropriate regional organization if that is applicable to you. So for Latin America, there's FLAME. For Africa, there's IFEM. There's also ASAM and the European Society. So if you don't fall under any of those, you can apply for the course directly through IFEM, but that is a bit more of an involved process. And then obviously you want to have local oversight and a sponsoring organization in country as well. If there's a national professional society, then you want to involve them as well, obviously, too. And Ministry of Health. And I think that's it as far as my section. Yeah, the next one is gonna be icebreakers. Any questions on overview of the course or any of that? And we'll get into more of the nitty-gritty details later today.
Does anybody have any questions for Dr. Mackey? Okay, very good. Thank you, Dr. Mackey.
Yeah.
Since we have a couple minutes here, I wanted to just clarify that the way it works for this course, since you all have not done the BEC course, is that you are going to be accredited by SAEM, but in order for you to be accredited by IFEM, which is the governing body for this, you will need to, at some point, be a participant of the BEC course as well. So it doesn't mean that you can't teach, it just means that you would, in order to go through the pathway as Dr. Mackey described, you'll just have to go back and do a BEC course at some point, which can be a fun experience, so I recommend it. So without further ado, we have Dr. Travis Wayland, who will be coming up from EPPA, and he will be just leading some icebreakers. He has done work in Kenya and Rwanda.
Yeah, so taught in Kenya a couple times and then Rwanda as well. I'm Travis, nice to meet everyone. So I want to start off just by talking a little bit about icebreakers as you would conduct the course, and then we'll do an icebreaker ourselves. So in the past, when you especially when you have over the course of days, the icebreaker is nice to get everybody familiar with each other. Depending on where you're working, some cultures will be a little bit more hierarchical. It can kind of help to pause that for the purposes of the course so that everybody can feel free to interact during the course itself, because it does require a lot of participation. So in that spirit, for example, the last time I taught in Nairobi, we had our each separate groups, and each day we'd have a separate group task. So the first day they came up with their group name, and then they drew a mascot, and then we put their posters on the wall around. Then the next day they did a dance with a song tied to it, so it gets everybody awake because it's early in the morning, and it was I think appreciated by everyone. Everyone had a good time with it. But you can do whatever you want with it. It's pretty much an open forum. So any questions about that? It's pretty much, you can kind of make it into what you want to, but if you make it group-based, a little bit more interesting. So, all clear? Okay. So for our icebreaker, my thoughts were, we're not going to come up with team names, no team mascots, but one thing that I've done in the past that is kind of a fun thing is a rock, paper, scissors tournament. So within your individual groups, you're going to choose someone, and you're going to do a quick round of rock, paper, scissors. And then if you lose, your enemy is going to become your friend, and you're going to be that person's cheerleader. And then that person's going to find the other person that won. You'll do rock, paper, scissors, and so on and so forth until we have a champion at the front. So, and the only reward we have is undying glory. So no actual things, unfortunately. So yeah, you can just find somebody who's next to you. One and done. One and done.
And also make sure to introduce yourselves in the process.
Yes, introduce yourselves before you actually throw the round.
Go into combat.
A little bit closer. Oh yeah, sure. That'd be awesome. Thank you. When you have your table champions, you can find another group, and then you keep on going. Keep going. We're going to have a grand champion of the room. Who's our winner? Find our next one. He's the champion from their table, so, all right. So you are all his cheerleaders. You can come over. Oh, just for time's sake, we're going to do one. Sorry. So champion, now you all are his cheerleaders, so you'll find the person at this table. All right. Do we have? All right. Oh. Oh. Are you in? Oh, we have another matchup. All right. The suspense is palpable. It's a good final round. Oh, all right. Excellent, excellent. All right. So that's just an example. It doesn't have to take a very long time. Just gets people up, gets people awake, gets people talking to each other. So that's how we do icebreakers. I will talk to you again in 2 lectures.
Thank you so much. Okay, so it's my pleasure to introduce Dr. Shama Patel. She is from the University of Florida, and her main site for teaching the BEC is in Ethiopia, and we're very lucky to have her because she also was a regional chair for AFEM as well. Thank you.
How are you guys? Hey, is it working or not? Can I just talk?
Yeah.
Just loud. All right. What's up, everybody? All right, teaching and learning. Are teaching and learning the same thing? Let's get around here. Why no?
I mean, so teaching is providing instruction and learning is absorbing that instruction.
That's the best answer I've heard in 4 years. I'm supposed to say, I'm not going to ask anybody else. I'm like,
Wait, did everybody hear that?
yeah, can you do that? So, we're talking a lot about, really? Need it? All right, fine. All right, so when we talk about teaching and learning, we're talking about teaching BEC in a lot of different places. Places that don't have the same way of teaching. Some may be a bit more formulaic, a bit more patriarchal, so you just need to know the setting that you're in. And just talking to people and not engaging and not having them kind of repeat and making the connections isn't going to help them actually retain the information. So this is just Snoopy. Very old. All right. You don't have to prove that you're smarter. I think the best thing I've learned over doing BEC since like 2018 is that first, get the lay of the land where you're working. Have your local champions and your local partners. This should never be done where you're going in. I think we used to talk about this a lot more like 10 years ago. I think the new generation of people understand that we're trying to do it from the ground up. It should be in-country end user-led, like what they need. Also, this is probably controversial, but whatever, I'm gonna say it. So BEC can be modified. They're gonna say you can't modify it. You can totally modify it. It's a free access, open access, it's fine. So like some places will want other information, like some places will want ACLS, some people won't, some people will want more advanced training. It depends on your audience, so just understand that. So it should be end user led, and you should be invited to the country. I don't know if some of you know, I'm really big into the decolonization of global health, so you'll probably hear that a lot in the next 5 minutes, 10 minutes, whatever, how long it takes me to do this. So your job is to break things down logically. Remember that the language barrier, it took a long time to get this into Spanish, and now I'm glad it's in Urdu. They're talking about Arabic, all the WHO languages. It's been a long time coming and still not there. It should be done in the local language, but I mean, it's difficult. But you should have people that can understand both at each group, with each person, so that you're understanding they're talking. Because especially if you're coming in as an external person, especially from the West, they're gonna be scared to ask you questions, so make it as comfortable as possible. So what makes a good teacher? Not you. I feel like you can't answer any more questions. That's good. Mic drop. All right. What makes a good teacher? I'm gonna start calling on people. There we go. Flexibility. Clear communicator, which I clearly am not, but what else? Interactive, yep. Yes, I think that's great, good listener. Listening to what's going on. What else? Prepared. Yes, prepared. I would also say spontaneous, because things will happen. No BEC is ever run the same. It's always different. And it always teaches you something. Anybody else? All right, so this is a constructivist theory. Basically, it just means that we're active learners. We're not just being told kind of in school. I think even in grade school and middle school and stuff, they're teaching this kind of way, that you're just not taught like rote memorization, that the way that you can understand things is by making connections and active learning. All right, so cognitive load. There's only so much amount of information you can take. For those of you who haven't worked in country, or a lot of you have, our emergency medicine colleagues, both nursing, health officers, physicians, have multiple jobs because they're usually the only ER physicians in that country. So they're working at the Ministry of Health, they're working in public health. Like during COVID, they were leading the response to COVID. So they only have so much time and information and brain power to listen to us and work. So remember that just because we're there and we're their captive audience, they still have 10,000 other jobs because they're the only people in that country that are doing this work. So, all right. So intrinsic load is the amount of brain space you actually have to just learn something, to absorb something. I should say not learn, absorb. Extrinsic load is everything else, like the room temperature, how things are set up, like do you have a bunch of other distractions, which obviously our colleagues do, all of that kind of stuff. It's not 100 degrees in Phoenix right now. No one told me that. And then the germane load is how you make the active connections. So it's your knowledge that you receive, all the other extrinsic stuff, and then how you make those connections. And actually absorb the information and make it part of your daily practice. All right. And then the goal is to minimize the amount of red. I think as emergency people, we all we do is kind of live in the red. Everything is always noise, everything's beeping, everything, we're just on overload. So I think we're good at this, and I think people that are taking this course in different countries are good at this, of processing all that information, but limiting the amount of the extraneous stuff will actually help internalize what we're teaching. All right, so the 4 key elements of any teaching session is environment, set, dialogue, and closure. So what do you guys think about this environment? You comfortable? Like, what happened? Yeah, so not a lot of distractions, that's key. I would also say round tables are good. Anything that doesn't put any division between you and your learners is also good. Anything else? Good temperature, good lighting, all things that are not always possible, but Because I've been in places where BEC has been taught and then the electricity goes out and then you're just kind of having fun, doing things. All right, so temperature, light, layout, equipment. All right, set. So credibility, you want to give people the due respect and kind of where they're from, and be credible with what you know and what you don't know. So don't say that you're this great expert of emergency care because you were taught in the US, but really also just say, hey, I have done this. This is my experience. So just be credible with what you do. Introduce the topics. So a lot of these topics, if you guys have seen the BEC course, seem very simple to us, but when you actually teach it, it's much more difficult to actually break it down and teach skills, teach ABCD approach, because a lot of people don't know that. That's a very emergency medicine thing. And remember, emergency medicine is nascent in many countries, including Europe, including a lot of other countries. People think that it's just low and middle income countries that are developing emergency medicine, but countries in Eastern Europe are all over, so remember that. Inspire, interest, and motivate. So as much as you can bring in local experience, the better, because there's different medicines, there's different equipment, there's different ways of doing things. If you're in a culture that is much more division between male and female, who is treating who, all those things need to be considered before you start a BEC, not while you're doing a BEC. And what your learner baseline knowledge is. Pre-test is fine, but you really want to know who you're teaching. Are you teaching nurses? Are you teaching health officers? Are you teaching just general practitioners? Are you teaching EM residents? Who are you teaching to teach this? And that's going to be a big point in how you actually implement this. And then the learning objectives, which can change based on who your end user and your learner is. So dialogue, clear, logical. So I have a big problem of mumbling and talking very fast, which it hasn't changed. So I don't think it's going to. 42, it's not going to change. So I just kind of go with it. But remember to be clear, concise, and culturally appropriate. Organized, comprehensive, and then engaging and interactive, kind of self-explanatory. And then closure. So this is I think this is the best part, asking what you learned, what things are confusing. Also don't, so in some places I could put people on the spot here because that's our culture, right? In the US we can do that. And Ethiopia, if I ever did that, that would be not good. It would have caused a lot of problems. So just remember that. Obtain feedback in multiple ways, let them come talk to you, but also do it anonymously. Let them do it after when they've had time to process. So just have multiple avenues of feedback. And then always have next steps, this is the next step. So if we're training trainers, if we're just training people on BEC to just use it, what are your next steps? How do you have follow-up? Also remember, just don't leave them high and dry, right? We know that teaching courses and then you just leave them, then they're not gonna retain that. So have check-ins, have supportive supervision, there's been various models throughout the world of people doing this in different ways. So they'll have WhatsApp groups, they'll have check-ins, Zoom calls, whatever. I think a lot of things COVID did bad, but one thing COVID did good is telecommunication around the world is much better now. So we can do those things. And then summarize kind of what was done. And then vary your tone. I use a lot of comedy and just self-deprecation is kind of my thing. Emphasize key points. Move around the room, and then try not to stand at a platform, which you've seen all of us so far do. We're kind of engaged with you guys and stuff. All right. How to handle common teaching challenges. What if you don't know the answer? I had attending once that was not like this, and they're like telling me all the wrong things, and like, oh, well, I know the answer, and this is it. And then I would go back with like, a paper, because you felt really smart when you're an intern. You're like, well, the evidence shows that this is wrong, and this is how we should do things, instead of just saying I don't know the answer, or like let me check it out. I think that's the biggest thing we can do is I don't know the answer, and also just ask in-country folk, like, oh, what is it that you guys do? Like, so you have a patient that has just a snake bite, like what is the process here in this country to respond to that? Like for example, there's been controversy over the opioid use. That's why it's not mentioned in like the traditional BEC, because there was a big controversy of like, oh, we don't have opioid use in certain countries, and so it wasn't actually put into BEC, but a lot of people are adding it now given like opioid crisis and stuff. So it's okay to admit that you don't know, especially when this isn't your country of origin. And even if it is your country of origin, there's always something to learn from the people that are doing this on the ground. I love this one with residents, like, oh, I don't know the answer, but I'm not gonna tell you I don't know the answer, but hey, why don't you look it up and come back and talk to me about it? It's the best trick ever. Have a parking lot so that you're not always distracted. Because people will start engaging. The first day is usually kind of slow going, people are getting to know each other, and then people will start really getting into it, but then there's a lot of distractions, and you have to get through the material, and it's a lot of repetition, so you want to kind of distract yourself, but put things in the parking lot that don't need to be immediately talked about, and then don't make up an answer. If you don't know, especially if you don't know what that country protocol is, what the Ministry of Health protocol is, then just ask, like take the time, look it up. And if you can't get the information in that 5 days that you do it, or however you structure your course, just make sure that you have a way to get back to the participants. Oh, sorry. So what if some aspects of BEC involve equipment that the participants don't have? So this is super important. A lot of the BEC tries to use low fidelity simulation and different tools that could be available, but really know what they have and who your end user is. Like if you're teaching at a capital, they're gonna have different tools and materials and medicines than they are at the local level. So just know that and adapt as you can. And then WHO teaching strategy. So it's student-centered philosophy, right? We're all adult learners, so it's all, I would say, end user led, kind of what they need. There's some information that needs to be done, but a lot of it's gonna be adaptive. And the group size, so this has been the traditional, like you want one facilitator for every 6 people. Sometimes it can happen, sometimes it can't. This is actually very good because then you can have the small groups really engaged. And then it should be as interactive as possible. And then use slides for key concepts. The slides for BEC are very dense, and there's a reason for that. It's because some people, English is not the first language for most of the world, and it helps reiterate what we're saying. So they'll listen to us, but then that's why they're so dense, because when we do lectures, it's like, you can't have that, you shouldn't have that much, you should have like pictures, but that's the reason behind why BEC or slides are so dense, is to reiterate the information and help non-native English speakers too. And then supporting, again, always have a plan on how you're gonna reach out during this course and also after. Yep, supportive, we all know this, like just be a mentor, supportive. Also, don't be going in there thinking that you know everything, and just kind of let the end user and the learner lead you. And then just be around to take any questions, and be open. And they're gonna ask questions that you may not know the answer to, you may know the answer to, that make you uncomfortable, make you not, because like some of this stuff is like ethical dilemmas of like, if I have this patient, but I don't have this equipment, do I even do anything? And answering those questions are difficult, and that's when you rely on your local champions and your partners. And then remember this, you're training the pioneers in emergency medicine, which is very true, and it's very humbling. Questions? Cool. See you in a bit.
Thank you so much, Dr. Patel. Yes, thank you. So Dr. Wayland, if you don't mind coming back up, he's going to be talking to us about what not to do.
So this, upside down, what's wrong way? Cool, all right. So essentially this, whoa, that's much louder. He told me to hold it closer, so there we go. Hopefully everyone can hear me. This is just basically a long litany of do nots, which can seem a little bit negative, but it can be helpful to help direct you in the best way to conduct the course. So the first thing is to not skip the basics. Shama has also alluded to this. A lot of this material can seem fairly, basic to us, but your group is going to be mixed. Some might be, an experienced attending. So it might just be a new grad nurse that's just coming out. So the fund of knowledge in your group is going to be highly variable. So keep in mind as well that we don't have a lot of time, so reiterating those basics again and again is going to be the best use of it, because repetition is really the mother of all good learning. So to keep that going, it's going to be very important for you to not skip those basics and to stay on track with everything. You will get a lot, as Shama alluded to as well, of people wanting to add on other skills or have extra questions about things. And it's great because they're very eager, they want to learn more. But using some of those techniques to kind of table that, or say, like, we can talk about this after class, can really help keep your lectures on point, because if you let everyone ask every question and answer every question, you're not going to get through the material, which obviously everyone suffers then. So. And then leadership requests for modification. In general, this is something that you can take on board, but you wouldn't modify any course material on site. As we mentioned, don't take anything away. You can add something, but don't take anything away. So. And then the other thing is to keep in mind that you're coming into this situation, in most cases, unless you're teaching in the United States, as an outsider to your group's culture, and to their medical system and their way of doing things. So be aware of that, and just modify how you're interacting with folks based on that. Know who your audience is. Know, is it mostly physicians? Is it med students? Is it nurses? And know how to sort of change that, change your material and how you present it based on those. And this is another important thing too, because as you teach in different places, each country and each culture is going to have its own hierarchy, and being aware of that before you go in will be important. Sometimes it's something that culture would be okay suspending hierarchy temporarily for the purposes of a small group interaction. In other cultures, it will be, if you have a small group with doctors and nurses and med students, nobody else is going to talk but the attending. And obviously that's not constructive for everyone. So you try to deconstruct that as much as you can and to make it a very sort of horizontal structure while you're doing the course. Sometimes, just by your best efforts though, it just doesn't take, for lack of a better term. So you can break people into groups according to their peers. So like this would be the nursing group, this will be the attending group, and so on and so forth. So just don't, if it's obviously not going your way, don't try to fight it. Just, you can adapt to groups as needed. And yeah, this is basically just what we said. So, and we've gone over a little bit of the language modifications as well, that we're trying to get more courses that are not in English, but ideally one or more people in your leadership group will be bilingual. So if there's like a word that somebody doesn't understand, that can be translated or interpreted. All right, don't skip the repetition. It's the mother of all good learning. So you'll over the course of this, since nobody's actually taken the BEC right from the group, so you'll be like, my God, this is like the 18th time we've seen this. Like, do we really need to say it again? Yes. Because remember, you have people of all different levels, and if they hear it again and again, it'll be automatic, and they don't have to, think too much when they're under pressure in a more emergent situation with a patient. And then don't be afraid to ask. This kind of ties in with the cultural humility that we were talking about earlier. If you don't know how something functions in the host country that you're in, or what resources they have available, or what their sort of setup is, don't be afraid to ask questions. Nobody will fault you for trying to learn more in the service of being the best facilitator that you can be. And do not underestimate your champions. Several of the other speakers have talked about identifying those people that you know are going to be really gung-ho, and you can kind of identify them early on. They'll usually be kind of like the first ones there. They'll be very eager. They'll ask a lot of questions. You can tell that some participants are definitely more into this than others, and try to invest in them, try to develop that, because they're going to be the people that will mean that you are redundant and are not needed to teach this course in the host country. They take it from there. Yeah, so, and that last point, you can't emphasize it enough, that it's great if you go, you kind of, you're invited to a country, you do the course, but after you leave, if nobody is there to carry the baton, as it were, then it's not really gonna go anywhere, right? So, do not let people sit quietly. This is a very important element, and there's a cultural element to this as well. So in certain educational systems, the pattern is, you sit, you receive knowledge, and then you just kind of go take an exam, and then you're done, right? But one of my attendings in residency always said that education is treated like therapy. It's treated like a massage, and it should be a workout, right? You need to be interactive. You need to actually get people involved in the material as they move through it. So, and you have to purposely call people out if they're not participating. You try to make this like as unintimidating as possible. Like if you ask a question and the answer's on the slide, you can call on someone that's been quiet and been like, point to it. And even if they just read it, that means they're talking and they're participating. And that can break that ice a little bit more so that they're gonna be able to interact. And you can see over the course of the week, people get more comfortable and more interactive. And then ask the group to summarize. This is kind of in the vein of the, the teach back kind of that we talk about. Like, okay, what is your understanding of what we just talked about and what we went over in the lecture? And that can be a useful way to gauge if what you're saying was received and people are understanding. Yeah. All right. Any other thoughts, questions? No? All right. Very good.
Okay, thank you so much. So we're going to have a quick break for you all to just stretch your legs and get some more snacks. Let's plan to come back at 10 a.m. Or let's make it 10:05. 10:05. That's 40 minutes, you're right. I can't do math. Yeah, just do 15 minutes, so come back in 15 minutes. You guys do the math. I'm not really great at it right now. 9:30. Thanks. Oh, yes, I am. Okay, let's get back at 9:30. Thanks.
Maybe you're going to go over this at the end, but how do we actually find a basic emergency care course?
So IFEM has a website, and there's master trainers on there and websites they go to.
Okay.
And so you can reach out to those people. Also, just like word of mouth. So you're here right now. A lot of us work in the States. Like I work in Pakistan, Dr. Patel works in Ethiopia.
Yeah.
So it's usually best to do it that way because sometimes, as local health physicians, we're not always great about checking our email. I would say that for myself. But like, touching base with the facilitators and, if it's a place that you want to go or, and saying, hey, here's my contact if you're going to be doing this in the future, involve me. And we're always looking to help, so you'll find it. Yeah.
Okay, awesome.
So I recommend that.
Okay, perfect. Thank you.
Oh, that's why you said 10 a.m. Because you're looking at the schedule.
I was, yeah.
Wow, you're super early. Yours is good.
I mean, hopefully you finish early because this is otherwise a very long day every single day. And to be
Hey, hi. Yeah.
So since no one has assigned lectures, like a lecture card, do you want to give people like 5 minutes to review like
chilling out here.
the first 5 slides and the next 5 slides so that they have time to review? Do we have any more time we can build into the lecture card?
It's 45 minutes.
I'm guessing
That should be enough. We're already running early, so if we go,
So if we give them 5 minutes, because 45 minutes 6 people in the group, right? So that would be like 5 minutes to lecture and 2 minutes for feedback.
So probably make it an hour.
We could. We could see how people go.
Yeah, let's do it.
That way that gives them some time to like review.
Yeah, I'll change it to an hour. I'll adjust the time. Okay. Oh, that's okay. That's all my
I was like, Holly's checking one. Why? Us those questions.
No.
Okay, can you ask if the people that are running the course are in the lecture? Is that okay? Okay.
No, you get food.
No, so we just want to make sure that it's not, but you mind asking if it's best. If the facilitators, like the people running the course, will also get lunch, or if it's just for the participants.
I forgot since I'm
You're gonna get
Yeah.
we are the ones that have to yeah, probably. It's like usually a box lunch. Just grab like 10. It's usually your shitty yeah.
Okay, I have to quiz you for this lecture that I'm giving in 8 minutes.
What's the other lecture?
Did you fill in the water bottles space your exam?
What do you need?
Yeah. So it's the how to give a lecture, which mom is doing next, and then we want to do
So the teaching skills is on the Google Doc, but the water bottle spacer, have you ever done that? No. So do you mind doing me a favor and finding out who in the group has done that and feels comfortable taking over that lecture?
Okay, so wait.
Specifically, no showing.
Okay. Okay.
Like, just
where? Can you just show me where the teaching skills are? Do you want me to do that, or do you want her to do everything?
Well, because the teaching skills
It's all
goes
combined.
It's all combined.
Okay. All right. I'll ask Sean.
there's a video online of the water bottles.
So she's done it before.
Yeah, I
so-
agree.
And then the other thing is, if she can't, then somebody else. And this is just as backup in case Mary doesn't.
Okay.
Hopefully Mary gets here. If you don't mind. Thank you. Let me know in the chat. You definitely sent it.
I guess, right? Yeah. It's somewhere. I'm trying to find it.
Oh, yeah, wonderful to meet you. And
Oh my god, I hate to be close.
Okay, yeah, I found it. Yeah, it's right here. Yeah, I definitely saw this recently every year.
It seems pretty straightforward.
It's very straightforward. Literally just cut out a hole to put the yes, and then and then you just yep. That's basically it. Are you guys doing it today too, or is it
So I get 15 minutes to do this lecture.
yes?
you all are incredible.
It's all normal. I'm just sitting here.
I was just curious if Mary doesn't make it also. I think Nisi is also a master trainer. Maybe?
Yeah.
I don't know.
Well, I was wondering if somebody, because I mean, it's in 5 minutes. I feel bad to like
No,
anybody else.
sure.
I'll do
There's
it.
one lecture in 5 minutes and one at 1:30.
Yeah.
So if someone wants to do a lecture in 5 minutes, so Maham can coordinate.
No, it's
Yeah.
okay. I don't want to put it down.
Well, any of us would be happy to.
Oh, really?
I think so. I'm still provisional also, so I don't know if I'm allowed to.
We have a provisional
So.
because I've done the BCTO.
Would you like to do the lecture?
I mean,
We have 5 minutes.
well, what I was, Nisi is, I think, signed off. She's at the tip of the Joy from Belize.
Yeah.
I think she's like a master facilitator.
We're going to ask her.
She already has 2, so I already asked her.
Nisi or Nisi with Joy, the physician from Belize.
Hi.
Hi there, I had a quick question for you. So you said you're working on the translation to Urdu.
Yes.
So I have been requested from the WHO collaboration from India to start working on a translation in Hindi. How do I go? What is the process that you take?
Okay, good.
Can we talk a little bit later?
Yeah.
Yeah, because I have something that I have to do right now, but
Yeah,
I'll catch
absolutely.
up with you.
Come on.
Okay.
Yeah,
Okay,
I have-
nice. Yeah, we'll catch up.
Dan, he's wonderful. He wanted you to do it at lunch.
Potential advantages and disadvantages to what? Understand potential advantages.
And if you're PGY fluent, you can also work with the banks.
So, I texted and tried to call Mary
I'm just learning first line. It's just something I'm going to do right now.
because she's.
I might actually
Absolutely.
can we push it back to Drake a little bit so I can tell Tom about it? Let's push back to Drake a little bit. Because I need time.
And maybe she'll show up, but I'm like, because she doesn't have a SIM card yet, so she's Wi-Fi bound, and she's not on Wi-Fi, which means maybe she's in and out.
Okay. So, Mary, and then can we find out if somebody can cover teaching social protocol space, for example?
Yeah. And I can probably do that. She should be here by then. Hopefully, one hopes. Because that's after lunch, right? Yeah. So, yeah, I'll try to call her again.
Do you know if the online BEC course counts as
I'll have to look into that.
Yeah. It's online, and like most of us are doctors and don't have 5 days to go.
And I know during COVID it was online entirely.
What's your name?
Just volunteer. Sorry, it's not that. Possibly.
Oh, no way.
Small world. I'm doing my master's there right now.
Oh, right. You can.
Yeah, awesome. I'm doing the online master's in health professions education. It's like great. That's cool. What a small world. Thank you guys.
She might also be thinking, oh, I have till 10. I'll keep trying her. Yep.
Disaster response do a lot of work.
So, I don't know, you have to
doing local. I wonder if you have someone like that at your institution. I can't think of anyone like that.
Oh.
Yeah. I'm actually taking it. It's a humanitarian response course. I'm taking it. You can also take it virtually. That's true. We do offer grants specifically for the Johns Hopkins one. Obviously for me, everything's paid by the university, so I can't right, it gets used up with all of the
You don't know if they're
and stuff.
there's
But yeah, I totally get where you're coming from. I'll look or I'll give you my
Are you like this one? Oh, he loves that one.
Oh, I just want to make sure everybody has to use the mic because of the records back
Okay.
there.
Yeah, I'll make sure that happens.
Because I think your organization does something with those to provide it to members or whatever. Okay, awesome.
Hey guys, we're running a little early on time, and just so that we have lunch at the right time and we don't have a lot of filler, just take another 10 minutes of a break now, and we'll get back into it at 9:40.
on the way. I'm trying to ask her what time. Sure, she said she'll be here in 15 minutes, so. Yeah, that makes sense. She apologizes profusely. Yeah, perfect.
Okay, everyone, if everyone can come sit in your spots, we're about to start. All right. If everyone can have a seat, we're going to resume. Boom, 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 boom. Okay. So as I told you earlier, my name is Maham. I am a global health physician and a fellow currently. I'm about to finish up at University of Pennsylvania. And a lot of my BEC experience has been in Pakistan. So Travis gave us a really great lecture on what not to do in a lecture, and so I'm going to follow that up with what we should be doing. So just the objectives of this lecture is to firstly understand the potential advantages and disadvantages of giving information in the form of lectures. And then we're going to discuss how to deliver an effective interactive oral presentation, as well as engaging with your learners. So I'm a very interactive speaker, so I'm going to be going around asking all of you, and so I just ask that you guys work with me. So just a couple advantages. So lectures, they disseminate information to a very large group of people. It's very effective. It's cost effective as well, and it can be inspiring because it can be a conversation as well. It gives you a big picture, and it allows plenty of supporting media. So usually we give PowerPoints with our lectures. So limitations, it's good to know the limitations of giving a lecture as well. So learners have to go at the same pace. So some people engage with information or learn it at different times, and also our attention spans differ as well. So some of you are paying attention to me, and some of you are not. And I totally understand, because we can't always be engaged at the same pace. Well, that is one of the drawbacks of giving a lecture. So it can be difficult to get everybody involved. concentration spans differ, as I said. And it's not always adapted to the appropriate level. So that's something that we have to be aware of and be very mindful of whenever we're giving lectures, is that you must know your audience. So is my audience more of a lay audience, or are they physicians? Are they in the middle, learners, medical students? Knowing your audience is very important because it can change how you interact, what language you use, and the speed of what you're talking about and what terminology you use as well. Okay? So planning the presentation. Every presentation should have learning objectives, also key points, and you want to engage students with specific questions, both to the group and also specific students. And also, whenever you're creating your presentations, having notes to yourself is always very helpful. And I'm sure plenty of you have given lectures in this room, so this is probably basic, but just reviewing. And then always finish with summary, questions, comments, or activities to kind of round out and solidify the information that you've delivered orally. So let's talk about effective presentation skills. This is where I ask you guys, what are some effective presentation skills? Not reading the slides. Yes, I agree. Anything else? Lots of visuals, very good. So the presentation itself, having visuals is really nice and can help keep learners engaged. What else? What are other presentation skills that are very important to keep people engaged? What are some things I'm doing versus what are some things I'm not doing? Asking questions, very good. That can help keep everybody engaged and a part of the process as well. So it's not just us speaking to you, you're an active participant in the lecture, right? Also, being aware of your nervous tics, being aware of how fast you're speaking, how maybe you're speaking too slow. Those are all really important things to be mindful of because they can be distractors and diminish the quality of your presentation. So just a couple more effective presentation skills, making sure that you are enunciating and also keeping in mind what languages that the different participants are involved with. Sometimes it's even something to think about that maybe you need like somebody who's a translator in the audience who can kind of come back and give a summary of the lecture that you gave. That's something that people have done in the past. Also, there have been people who are, only speak sign language, and so having a sign language interpreter in the room, just knowing your audience and knowing what will help to deliver the material most effectively is very important. And so just speaking of the use of voice, what are some things that you look out for whenever you're giving a presentation? I know a lot of you have given presentations. So when you're using your voice, what are some things you're thinking of? Enunciating clearly, speaking slowly. Projecting. Very good. Not using filler words like like is a big one for me anyways. Anything else? Avoiding idioms, that's really, really important. So especially in our field, whenever we're going to different countries, different cultures, they may not understand the idioms of your local language. And so avoiding those is very key as well. Also, a couple of other things just to point out is if there is new language on the presentation, it's important that you explain what that means, like any acronyms or any words that may be new to the audience. Just taking your time to explain what that means is really key. And so engaging with your audience. What are some ways that we engage with our audience? And we talked about asking questions. What are some other ways? Walking around the room, very good. Dr. Mackey, who was here earlier, did a really good job of demonstrating that, and Dr. Patel as well. Anything else? Eye contact, yep. Having good eye contact and engaging with whatever questions the learners may have, those are all ways to engage. Sometimes also I wanted to bring up something about this. engaging with your audience in a culturally appropriate way. And so that means that, you know, I am a very jokey person. I like to come up in front of a crowd and just kind of have little digs there that are like a little funny, but not every audience enjoys that. So you have to know what country you're going to, what culture, and if they find it appropriate to have jokes in a presentation, because your credibility may diminish by you doing this. But there's other cultures, like I know in the US, that's very highly sought after. You know, it's really nice to engage and make it light at times. Not every culture feels the same way about that. And so one way to make sure that that is hit is making sure that you talk to your local champions, whoever is working with you in whatever country you're in, and talking to them about the culture and how they give lectures. I don't think it's necessary to completely turn yourself into, you know, that lecturer, but being respectful and mindful and knowing how the learners best learn is really important, and trying to assimilate that into your style. It's difficult, but it's very effective. And so just asking questions. So specifically about asking questions, because I think that's the easiest way to engage with your learners. Ask questions to the whole group, and then if you kind of get crickets, it's okay to stand in the crickets, by the way. It's perfectly fine. But if you get crickets for an extended amount of time and nobody's helping you out, then it's okay to say, hey, like, what do you think? You know, is it Tahir? Yeah, so hey, Tahir, what do you think about this question? Okay, so asking questions. So whenever we're combating answering of questions, so sometimes the person says the answer completely accurately correct, and you have no other problems, you just say, good job, and you move on. But then there are times whenever the answer is partially correct or it's completely incorrect. So there's two different approaches to combating that. So number one, if the answers are partially correct, usually what I like to do and what's written here is give positive feedback about what was correct, right? So if half of the question is correct, first highlight, oh, that is very well said that you said XYZ, but then you go ahead and correct any inaccurate information and make sure that the loop is closed. So that means talking to the learner and asking, well, what did you learn from that? What do you understand from that? And then if the answer is wrong, and I usually use this both whenever I'm teaching on shift as well as whenever I'm teaching in front of a crowd, usually what I'll do is I will say, okay, so your answer is this. So you basically give them feedback on what you understood their answer to be. That way you don't misunderstand what they're trying to say. And then from there, what you need to do is ask them a series of questions that helps them lead to the correct answer, okay? And so whenever we're in our small groups here shortly, we'll be given the opportunity to try to work with that, okay? Active listening, making eye contact, making sure people are understanding what you're saying, reading the room. You know, if you're seeing a bunch of people who are either like not making eye contact with you, disengaging or yawning, those could be signs that they don't understand you. So making sure you're aware of the presence of the room and what the feeling is. I mean, it could just be after lunch, and so everybody's like in a food coma. That's definitely possible. But another thing is that maybe they just don't understand you. So answering questions, repeat it for clarity. If you don't know the answer, say you don't know the answer. So we're all experts, but we don't know everything all the time. And sometimes our minds blank as well. Like we're in front of a large audience, you don't remember everything. So first of all, knowing who your teammates are. So maybe one person like Dr. Patel is like the expert on global colonialism. So if somebody asks me a question about global colonialism, I might say, hey, we actually have somebody in the room who's an expert in this. Let me go ahead and defer to her. And then allow your teammates to help you as well. Repeat answers for the benefit of the whole group so everybody understands together and we're learning together. So just in summary, define your learning objectives, know the effective presentation skills, engage with your students, use questioning techniques to engage with your students, and plan your presentation beforehand. Are there any questions, comments, or does anybody else have anything to add that I may have missed? Okay, all right, so then now we'll be able to have you guys all get a chance at presenting lectures. So you can stay in your groups, and we'll have some facilitators coming to your groups, and we'll give you a couple minutes to look over some slides and then present it. Any questions? Okay, very good. Thank you.
you're done and then let them know.
Unless they're really, really into like the admin, that they might like make an exception. You have to have a winning personality. It's gonna be fine. You'll find something in academics you might not find something that works you'll have to be creative. And you know what? It's time for me. There's plenty of reasons to find it. I was sad because I love Philly.
I'll see y'all at the GEMA meeting tomorrow. And are y'all going to debrief today? All right, I'll see if I can come for debrief. Yeah, so I have Ramsport orientation until noon. Yeah, incoming. Yeah, so I start in like 10 minutes.
I told her that every year you give me a topic.
Every year what?
You give me a breakfast meal.
Oh yeah, this is like our thing now.
I think next year
It's breakfast. We're gonna have to just find something. For sure. So I have Ramsport orientation, then we have our Ramsport lunch, then I have my first Ramsport meeting, and then I have a small break before the board dinner. So I'm gonna see if I can come back.
Take care of yourself.
Oh yeah. So.
If we need you, we'll let you know, but we're probably. But if you want to be in the picture, try to go back here.
At 5.
Yeah.
I think that's what I did last year. Like I came, I did all the setup, made sure all the materials were here, dropped everything off, and then at the end of the day I was like, and then I walked back out. And it'll be the same thing next year, but the year after, you know.
Yeah. Well, I mean, Sorry, team, to interrupt. We will end at 10:45, so plan accordingly. 10:45. Okay, we have 1 minute left for time. So we asked for a couple extra minutes, so take your time. 10:50. Okay. Is everybody finished? If the facilitators can give me a thumbs up if you're done, if you're ready to move on. Yeah? Okay, very good. Okay, so facilitators, you can stay with your groups because after this lecture, we will be getting back into groups for small groups. So feel free to stay where you are. Very quickly, we're going to have another lecture in between another small group exercise. And so if you guys can all join me in welcoming Dr. Eunice Cruz. She is from Belize. We're very honored to have her here today. She traveled all the way from Belize just for this, and she came in last night, will be leaving tomorrow. So this is a great honor for us to be able to have her here with us.
Hello. It's an honor to be here, actually. After teaching BEC for so many years, now I'm here, so thank you. I'm going to try to not make it as boring as we have heard other lectures before in our previous lives or in our previous experiences. We're going to be talking about how to lead case scenarios. So basically what we were doing right now was small group teaching. And that's what you're going to do with the case scenarios that we have in BEC. BEC has these case studies that we do, and it's easier for us to learn it if we're discussing it in a small group. When you're doing that, we have to make it as interactive as possible, talking to each other. So how did you guys feel about the experience you just had discussing in a small group? And I'm going to pick on Lisa because I already learned her name. So how did it go? How do you think practicing or discussing in this group went? Okay. Rebecca, I just know your name because of Joy. So, how did your team go? What did you learn, and how was your experience in a small group discussion?
It was good. It was good. We also had a very approachable facilitator, and I think our group is very engaged in terms of giving both positive and constructive feedback for improving presentation.
Okay. So, this is something that you need to take into account because you're going to be the facilitators. You're going to be the ones that are going to be leading these case discussions when you're teaching BEC. And being prepared is part of it. Sometimes when we're leading a group, if you are a facilitator like me that loves to talk, you're going to find yourself talking too much and then your group is quiet. Or you can be the facilitator, like the other me, that is very quiet, and someone in the group is going to take the lead and is going to lead your discussion away from your goals. So you need to keep that in mind. What do I need to do during this discussion? The environment or how you do it is very important. And the scene. Sometimes, right now, some of you have to turn around to look at me. If we're working in a circle, we all can look at each other and we can be discussing. But what if we are sitting on a square or a rectangular table and you're just sitting at the head of the table? You're going to be far from other people. And you're only going to have a few of them having eye contact. That is important because if one of them is not having eye contact with you, you might lose them, and you don't want to do that, okay? So you should ensure that everyone is participating. How do you do that? If you're the leader and you're sitting here and Rebecca is speaking, I can also look at each one around the group so that everyone follows me, so that we can be in contact with each other when we're doing it. As part of the group, you have to make sure that your group is also being engaged, that they feel comfortable speaking up. And yes, sometimes you're going to have that hierarchy that some nurses will not want to speak because there's a doctor that works beside them, but you can make the ground rules. You can tell them, this is a safe space. We can speak, we can discuss, but make your ground rules there. And it's going to make it so much more fun whenever they feel safe to speak up. And you're going to learn way more from them when you're doing that discussion. So the environment and how you set it up, it's up to you. You're the facilitator. You're the one who has to set up the environment. If it's too noisy, if it's too hot, in Belize it's humid, so we're sweating whenever the AC is not working, you have to try to make the best out of it. You can go outside, sit on the picnic table, but look for ways how you can change the environment. Teaching BEC is going to be challenging if you're teaching it outside of here. It's never going to be the same. No two courses are going to be the same. All of them are going to be different. You're going to have different challenges. You're going to get to the place, and sometimes you don't have a PowerPoint projector, you don't have the chairs that you want, the AC is not working, but you have to make sure that your environment, you change it, and you make sure that you set the clear statement of what is your goal when you're doing what you're doing, okay? When you're doing this in a small group, always choose someone to be the leader or to write notes so that in the end, they can give you a summary of what went on, because we're going to be discussing clinical cases. So this will be an example of one of the cases that you would have, and you can have one of your participants read it out loud, and then you make the questions. You're like, okay, so with this patient, what would be your initial approach? Then they will start discussing. And if you have assigned someone to write notes and to give feedback, in the end, you can have a summary and you're going to have reiteration happening after the small group. Keep in mind that not everyone knows how to go about doing case scenarios like these. We have people that have never had the opportunity to be in an OSCE situation, and they're like, what should I ask now? They know the material, but if you don't know how to guide them, they're not going to give you what you want. So explaining to them how it works is going to give you a better experience when doing it. And teaching them how to do the handover. I think that's the most difficult part of the case scenarios that we discuss, because a lot of people are not familiar with SBAR. So like Joy had mentioned, doing the handover lecture early on is very, very useful, because then they already know what is the right way to do it. So they will start practicing from the beginning with the small groups or discussions that we do in the first lecture, right after the first lecture. So doing that lecture early on is very important. And they can always use their books. Tell them, you have it, open it, use your computer, use your laptop. It's not a quiz. We're trying to make you learn. We're trying to show you where these material are so that we can use it afterwards. So you're not quizzing them, we're trying to let them know where it is so that they can use it afterwards. And with the SBAR, which is very difficult to teach, but once they get it, it's really important for them to practice it. And when you're teaching, know your geography or where you're going to, because if you're teaching, for example, if you're teaching where I work, we are the tertiary level institution. So we have to fix it no matter how. And whatever we need to transfer, if I say we need to transfer, it's outside the country. And that is not something accessible to us. But if I am working in the southern part of Belize and I know I can transport to the regional hospital and then to the tertiary hospital, then those are the things they need to know. So you need to know your audience and where they work, who they work with, what is their capability as an institution wherever they're working at. So that will give you an idea of what to recommend to them when they're doing this handover. So, what did we learn from this activity? In the end, that's what you have to ask. And because you assign someone to write your notes, that someone can give you a summary of what we learned and what were the pearls of the case discussion that we had there. And always start with your ABCDE approach whenever we're doing the case discussions. Now, anyone has any questions from what I just discussed? Because now we're going to practice and you're going to lead the case discussions in the next session. So we're going to break out in your small groups and we're going to discuss the case scenarios that we have.
So you have plenty of time for this section. You have a whole hour, so until noon, and then we'll be having lunch at noon.
wasn't for like like you said, I like the task. Yes, it's like a task. That, yeah. So I just
Her name is Mackenzie, and she is really, really sweet. And she works at it's called BEC.
Because for me, I'm not super picky about haircuts, but I'm picky about who dyes my hair.
She does a good job at mine.
Okay.
I mean, I thought so.
Like, I get nervous about dyeing my hair, like, but haircuts, I think, honestly, I've never been unhappy.
Okay.
Yeah, which is good.
Well,
Except for, I mean, I've been to great clothes, and I'm okay with that.
Well,
But that's, I don't do that.
I'm very,
but
very picky about that because she's walking distance from my house, so I like it. And she'll be walking distance from you too, because it's kind of in the middle.
okay.
That's Bobby Mack. So specifically, Mackenzie.
Put that like. Oh yeah, she has experience definitely with that. So they do look really good.
See, the thing about me though is that like I might struggle with something for like a year or so, email. But then like if I develop a system, I'm like the best. You know what I mean?
Your calendar looks amazing.
Yeah, like
I could not.
I just have to develop a system.
The actual system.
So what I need to do is, like I asked you, I need to ask more people who are on top of their email and see like what system they have, because it's hard to just have something looming over your head all the time, you know? Like I just want to like escape work for a little bit, you know?
Yeah. No, I mean, and honestly, I'm like not organized. Like, you know what I'm saying? Externally, I think it looks like it, but like everything's in my head. You know what I'm saying? Like I don't do the calendar thing. I just like
Everything was in my head before.
right before, and it was doable, but now it's bad. So like the only thing for the emails that I do really is I like pin the ones that are super.
Yeah.
I'm like, those are the ones that I need to respond to, or like I need to follow up on like one, like all those pen things. There's like one thing that I have to do when I get to Philly, like the FBI, where they wanted some fingerprinting, but I couldn't do that. They were like, come to pen and do it, and I was like, well, I can't do that until like the end. So I have like pins to be like, I have to do that.
Okay, that's
So
fine.
like, it's like things that I need to follow up on.
Love that.
But yeah, otherwise I do respond back to every email within 48 hours.
Okay, good.
That needs a response. Should we do like a 30-minute thing?
Yeah.
30 minutes? We're at 30 minutes now.
Let's get back to small group. So 30-minute warning. We have 30 minutes left in this group exercise.
No, I think everyone appreciated it. Lunch is at noon. And if you want me to do the time, I can too. You can focus on it. It's up to you, whatever. If you want me to do the time, I'm happy to do it.
Fine. I'm good. We're working. We're tag teaming this.
But yeah, let me know. Yeah, if you want to run it again next year, if you need someone helping, I'm more than happy to help do it.
Maybe I'll run it again. We could be co
Yeah. Yeah.
Security. Because I
It's whatever you prefer. I'm also happy to help. Like, it doesn't matter.
Let me think about it.
Yeah, think about it.
I definitely am going to be involved, but if you wanted to be just 1%.
Yeah, it's
But
whatever.
also you have to think about it a little bit more because make sure like timing wise you're thinking as far as like fellowship,
Like to SAEM.
like settle in a little bit
Yeah.
and then see what your schedule's like and then
Figure it out.
you know
But
like
you guys went to SAM both years, right? Like you went last year, you were here last year and this year. Yeah. And you get one conference covered, or is it two? One conference a year? Two conferences a year.
I will say financially you're
Really?
Penn is like
I come from a cheaper city.
yeah.
As you can tell.
Penn is
I kid you not, I was looking at my contract and some of my friends are staying in Boston. Some of them are leaving, but the ones that are staying are getting moving. And then we compared contracts. I mean, no, I'm just a resident. My life sucks too. But like, we compared contracts and yes, it's insanely different. Even the CFE is different.
I did not like my program. I mean, not that
Do you know the download of the program actually? Like, we are for MTH. Like, especially women who are not white. It's extremely racist. I've cried once in residency. It was because of the first program. The attendings are extremely good.
Like, what's up with the attendance?
Most of them don't do any credit programs, so they all like really bad.
Yeah, they're all great. I don't
But just so you know, like, we all like affiliate more with it. Like, we all perform as well. Like, everyone loves it more. Like, that's actually where we get our training, honestly.
Yeah. Do you guys get more time there?
No, we have 50-50. We all hate
That sucks. Maybe they could change that and do less
They
time.
won't do it because it's going to be, we're now becoming a corporation. So it's not partners anymore, it's Master Brigham.
Oh, didn't know that.
Yeah, it changed when I was second year. Yeah, so they bought partners got like kind of like conglomerated into Master Brigham. So now everything is combined. And there's no way we could ever fight our way out of it. But yeah, no, we all absolutely like you have to put your EKG leads on, you have to draw your own labs.
Sounds like New York City.
That's what actually it is. You have to roll your patients a CT scan.
That sucks. That's too much task switching.
But everyone loves their license. Yeah. Everyone does love the community site. Like the partner is really nice. Like one of my really good friends isn't attending right now. She like trained the nurses. They're better, but she honestly hates the program so much that she has not offered it. Like she's an academic faculty member, but she hates the program so much that she's now and she hates it because she's worked with us and all that. But she was just so adamant that she like
You gotta do what you gotta do.
General Penn is like
All right, everybody, lunch is in the back. So as you're finishing up, feel free to walk over to the back and grab some lunch. And lunch hour will be for the next hour. So please be ready at 1 p.m.
No, that's good. It's good.
We needed it.
Yeah, no, it's. I mean,
Thank you
been
so
doing
much.
this forever. So
Yeah, I know. It's natural for you. Okay, so you will be, and this might change.
I was gonna be back at 1:15. Is that okay? Is that enough time?
Yeah, I think that should be plenty, but just in case we're running a little early, are you okay with me just like texting you?
Yeah, just text me. Yeah. I should be back at 1-ish, but.
Yeah, okay, perfect. Get the teaching experience.
What else are you checking besides that? Just making sure they're good?
Just making sure that they didn't need batteries.
Okay. Yeah, I don't think they've stopped because that room's never fully emptied, but
Yeah.
they're pretty chill. I hopped in. I'll show you in a minute. They gave me all the diagrams. So I was in the back room with them going over everything. So he says, "Yeah, good crew. If you just tell us what you need." All right, these are here for you. Okay.
Thank you.
Thank you. Yeah.
power.
All right,
facilitators know them.
I just realized I cut it text wrong. It's supposed to be at the back.
Oh, yeah. I mean, wherever you can do it, it's ad lib, right? So. All right, everybody, if you can kindly please take your seats, we're going to start here soon. I do have a couple of announcements as well before we get started after lunch. I hope everybody was able to get their lunch and were able to eat. Did everybody get food? Okay, good. So a couple announcements. Dr. Shama Patel wanted me to relay that whenever we're giving the lectures, whenever you're doing the BEC course as a facilitator, you can add whatever you like. So if you like to add pictures or whatever you like, you can't take away anything. So if there's something on the slides, you cannot remove any information, but you can add information. Okay, so I just wanted to stress that. That's number one. And then after this lecture, we will be doing some hands-on procedural skills. So facilitators in the back, if you don't mind just setting up your tables. And then what we will do is we'll just rotate. As participants, you guys will rotate tables and try these different procedural skills, okay? I think there's something else, but I don't remember right now, so I'll tell you guys later. But I want to introduce a very, very special facilitator here today. This is Dr. Mary Gatau, and she's from Kenyatta Hospital. She came from Kenya to facilitate this today, so we're very honored to have her here. Please give her a round of applause. And she will be teaching us about how to lead these case scenario sessions. Or teaching skills. Yeah, here you go. Where's the little? I'll click it for you. Here you go.
Good afternoon. Good afternoon, everyone. My name is Mary Gitao. I'm a medical doctor from Kenya. I hope, thank you. I hope you guys can hear me. I know there's an accent, but I hope we can all understand each other. Right. So I started the BEC course in 2020, and I was trained by Dr. Justin Myers, also with Travis, and we've worked together. I've trained BEC twice back in Kenya, and it's my first time training internationally. So I'm really honored to be here. We're going to talk about the practice sessions and how to go about the skill stations when you're training. And just go straight on to the first slide. Once you come to the skill stations, you want to first start by explaining to the participants, why are we doing these skills? Why is it important? It's very important to start from there. Then after that, we demonstrate as a trainer. You want to first demonstrate it, and then you allow the participants to practice. And then, of course, you'll be training and supervising them as they go on. And you'll allow them, ideally, you should allow them to do it 3 times so that the skills settle in. But sometimes time isn't on our side. Right. So we've done, for us to reach this point where we're doing the skill stations, we've already gone through the theory bit of it. So it's less talking for us and more hands-on skills. Right. Before we go, of course, like we've said, we're going to set up as the trainers. You have to set up, and we'll go through everything that we need per the discussion. If we're going to do airway, we'll go through what we need, breathing, and the different skill stations that we are going to go through. We're going to have to set up the environment for that. And then what we're going to be doing with every skill stations, we're going to repeat the 5 steps. We have to start by, why are we doing this? So you want to ask the participants once again, why are we doing this? You want to do a short demonstration, and then you want to allow the participants to repeat the demonstrations at least thrice. That's ideally what BEC recommends. Right. So we'll go on to we'll just pass by there. We'll talk about, there's some skill stations that are a bit difficult, could be a bit difficult to teach, especially if you don't have the equipment that you need to demonstrate, and also depending on where you're doing it. So BEC, as you know, is a course for the underdeveloping world, like where I'm from, and sometimes you might not have the actual things that you need. So sometimes it becomes very difficult to explain the skills that you want to transfer. Also, it depends with the people you're gonna train. Not everyone you're training is going to be a doctor. You might train nurses, you might train paramedics, or just people who are interested in the community. So depending on the level of training, you need to calm down to the level that they are and use, the skills might be harder to explain. So you need to find ways to make it easier for the people to understand. So you want to just keep assessing how your participants are understanding whatever you're training. And sometimes to make the difficult skills easier to understand, you want to also use the participants as patients. You want to use live participants as patients, and you'll find that most of the participants will be involved. Right. So as for the techniques, I'm sorry, I'll just be looking through the slides a bit. Yeah, so we've said you could use the participants as patients. You could use another facilitator. If you're 2 facilitators or more, you can choose to use each other as patients. Yeah, you could create a mannequin from scratch, but that's a bit hard. I don't know how you'd do that in a setup, but you could carry mannequins if you have the resources and ability to come with mannequins. You can bring the mannequins yourself, maybe to the station that you'll be training. I think that's what Travis did. He joined us and he brought equipments from here to Kenya, and we were able to use the equipments that they came with. Right. All right, so we'll go through the A, B, C, D, E stations and the skills and the whatever we need, the materials that we need. So the skill stations, sorry, for the airway, yeah. So we want to do the basic airway maneuvers, you know them. That's for any unconscious patient. So we'll do both adult and pediatric cases. You want to ensure that you're demonstrating the head tilt, chin lift maneuver for both pediatric and adults. Another case that you're going to go through is the choking, and you're doing it both for an adult and a pediatric patient. You want to demonstrate the abdominal thrust and the back blows. We're going to be doing suctioning under the airway, as well as the insertion of the devices. So what you need for these skills, you want to have the mannequin itself, because you want to show the head tilt chin lift using the mannequin, and you want to have ideally two, a pediatric and an adult mannequin. You want to have the suction material, at least you want to have the suction catheter, which we call it suction catheter or Yanka catheter. You could come with a suction tube, but I feel like it's heavy sometimes and you might not have it. So you can demonstrate it with a picture, how the suction machine looks like, so that people know what the suction looks like. You carry also the OPA and the NPA, because you're going to demonstrate also how to place them under the airway stations. Next. Under the breathing, we went through the scenarios and we saw that most of the scenarios we were doing in the earlier cases will give oxygen. So you want to ensure that you have the materials for oxygen. Under breathing for an unconscious patient, you'll probably be doing a BVM or ventilation for them using a BVM, so you need a BVM material. For the complications under breathing, we talked about tension pneumothorax and open pneumothorax. So those ones we'll cover that under our skill stations. Making a spacer is also one of the skills we'll do, and we'll do it just in a few minutes, and then the breathing assessment. So for that, you want to carry your BVM devices. Again, you want two of them, one adult and one pediatric, and you'll be able to show the different face masks that you're gonna use for the different patients. You want to have a nasal cannula, of course, the different oxygen masks. You want to have a mannequin, if you can, that has an airway. If you don't have that, you just want to demonstrate it using one of the participants. Then you want to, for the tension pneumothorax, you want to have an IV cannula, whatever you'll use, the needle that you'll use to poke. You'd have tape as well. Tape can be used to create the air tension pneumothorax kind of thing when you have a balloon and a tape. You also want to have a stethoscope, because remember, we're gonna do the look, listen, and feel as well as doing the skill stations. So you want them to listen to the stethoscope. And then we'll have plastic bottles, and we'll demonstrate how to make inhalers out of a bottle, because most of the developing countries, they might not be able to afford a spacer for that. And the circulation, we are gonna look through patients who have bleeding, external bleeding. That's one of the scenarios we'll do. Another scenario would be the bleeding in a pregnant woman after delivery. That's postpartum hemorrhage. Also, we're going to do IV cannulation. Remember, it's one of the things that you do under C in any patient. So we're going to have the setup for that, which will go through the materials. Then IV administration for patients who are under shock. We'll go through that, and under special considerations like burns. So going through the Parkland's formula and everything that it entails. So under circulation, you'll start with an IV line, IV cannula. You'll have the IV material, dripping set, giving set. And maybe you want red food coloring to put under water, so you demonstrate the blood. You want to have the bandages that you're gonna put. You could even come with the vacutainers. I don't know if it's called vacutainers here. The bloods, it's called vacutainers, right? Yeah, you might come with the vacutainers just for more emphasis. Of course, throughout you want to have your gloves, your PPE, just for every setting. And then, of course, you want to have your sharps and your beans. Sharp beans, sorry. D, disability. Disability, we said you check for glucose. So you want to have a glucometer if you can't come with that. You want to also ensure that you're going through the pupil assessment, as well as you want to teach them and go through, in that station, skill station, you want to just ensure they remember how to check for the mental status. So you want to ensure that they know how to do AVPU, and you want to also ensure that they know how to do GCS. Here, you might not use a mannequin, because the mannequin won't respond. So this is where you use a facilitator or one of the members there, and you set up the scenario so that they're able to know how to assess the mental status. Then after that, we'd have the secondary survey assessment, which is more like head to toe. That's a whole skill station in its own. And you're going to demonstrate to the participants how to quickly do a head to toe assessment. For the head to toe assessment as well, you're gonna just probably use one of the facilitators, or you could also use the mannequin really, but yeah. Then some of the things that might help in the skill stations is printing out some of these things like the GCS, because not everyone understands what the GCS is. Yeah, you could also look for the local trauma guidelines and print them, but GCS is enough. All right, there will be a station on immobilization. So for this, you want to also cover the cervical spine immobilization, log roll, fracture immobilization, and pelvic binder. So for some areas, especially the developing countries, you might not find all of these things. So you might have to carry things like cardboards for splinting. You might want to carry sheets for pelvic binding instead of using an actual pelvic binder. You might, for the C-collar, you might, I think the best thing is just coming with the C-collars that of different sizes, just to immobilize the spine. And then you could also come with gloves and a tape measure, bandages. But mostly, I've seen us using a lot of cardboards and bed sheets that can work as well. For wound management, we will cover the skill stations on burns, on general wound management, especially like a bleeding wound or something like that. And then burns, we will cover how to calculate the total body surface area and the depth, and of course the Parkland's formula, which is for fluid resuscitation, and then how to manage a snake bite. So for that, we'd also need, most of the times, a cardboard, bandages, maybe a tape measure, and then you can print out 2 sheets, one of the rule of 9s for the burns. Rule of 9s is the easier one, and then we could also print out the Parkland's formula flashcards or a quick card. So these are examples of how to do a DIY. Here they were trying to showcase how to do IV cannulation and how to draw samples and insert fluids. So they used just a round rubber band on a cardboard, I think, and then they were able to put the fluids, and you could see that they were able to aim well and correctly. The next image is of them just explaining how to do a tension, needle decompression. They didn't have a mannequin, so they made a cardboard, and then they put a paper and drew someone's chest. They put a balloon underneath, and they were able to, locate the ribs. So you could do that, you could use that. This one is a log roll and how to place how to do log roll and also to place a pelvic binder. They were using a sheet that was going to be put around, and then they would they would tie around the pelvis. So yeah, those are ways you could improvise. Lastly, this was for fun. Ideally, the person should be at least lying on a bed and not standing. But yeah, this was them demonstrating how to do resuscitation. There's something, we actually do need a bed or a table, I think, where you're gonna put the mannequin or the participant or your fellow facilitator to demonstrate actual live patients. So those are some of the things that we need, even as we think of facilitating a BEC course. I know it's been a lot of me talking. Are there any questions? Are there any questions? Do you guys think you'd be confident to come to Kenya to train? Are you confident? Okay, great. We'll be waiting for you guys to come and train us. Okay, Dr. Maham.
Thank you, Mary. Now, quickly, before we get into our skills stations, I would like to introduce Dr. Rama Memon, and she is a fourth-year resident at Mass General Brigham, and she is going to be joining us at Penn this summer as a Global Health Fellow. Give her a round of applause, please.
Hey guys, so I'm just gonna go over how to make a makeshift spacer inhaler for with a water bottle, just to demonstrate how to teach this essentially. So you start off with just kind of demonstrating the skill. So with making this, the reason it's important is really to help medication go directly to the lungs by using a spacer, and also it limits waste of the medication as well. I did already make it just because we did have to use shears, but traditionally you would like to use a water bottle. You want your inhaler, you need tape for this, a pen, and also a scalpel or scissors. You put the inhaler at the bottom back of the actual water bottle. You want to trace it with the pen, and then you want to cut out that area and insert the inhaler actually through the back of the water bottle. You tape around the inhaler itself, which prevents any medication from going outside the water bottle. And then you go ahead and pump it 2 to 3 times, let the medication go in the water bottle, and then open the cap itself to have the patient inhale as well. Does anyone have any questions about that? No? Okay, perfect.
Has anybody made a spacer from a water bottle? Yeah? Where did you make a spacer from the water bottle? In the airplane. For yourself? No, it was for, I had a PES patient that was like on the airplane, and they only had adult inhalers. That's really cool. That's really cool. Were you trained in it, or did you just kind of like make it up on the go? Yeah. That's awesome. Who else has made it? Somebody else? Yes. What was your experience with it? Awesome. And then behind, the gentleman behind it?
Same thing, just teaching abroad, same thing, teaching patients and families how to make them. I've also done an adaptation. Sometimes the water bottles have like little feet on the bottom, which makes it difficult, to where we would actually just cut into the side.
The side.
As long as you're getting medication in the chamber and all that matters.
Yeah, yeah, absolutely. Awesome. Well, now it's the procedural skills time for that. So you guys can stay where you're at, and your facilitators will bring some supplies, and then we'll rotate every 12 minutes. And so we'll let you know when it's time to rotate.
air horn. Air horn. And just, you know. For like the slow people, you know.
So it only lets us project this.
Life is good.
Yeah.
SAM's got it locked in.
Yeah, it is. They do. They got it locked in.
right, you guys all have 5 minutes remaining in this session.
Oh, the 5 steps. Yeah, go ahead. It's all the way back, I think. Take it away.
All right, guys, time is up, so please finish up your teaching. We're going to have our participants rotate. So go to the next alphabet letter. If you're at F, then go to group A next. Everyone else continue to the next alphabet letter, and you'll have 12 minutes for this next session. All right, you guys have 5 minutes remaining. 5 minutes remaining. All right, everyone, please wrap up. Your session is over, and proceed to the next alphabet letter.
Sam or Samuel? Sam. Sam. Yep. Said called Timothy, but I'm Sam also. Nice to meet you.
I'm Ellie, but nice to meet you too.
Welcome. Washington. Amazing. Cool. Harvard Review. Naz, is that Seattle, right? That's amazing. Whoa, jealousy. Very cool. Where you're coming from? South Carolina. Okay. Awesome. Yeah. We've got Death by Firing Squad and Lindsey Graham, so I don't know. I've got a lot of mixed feelings. How do you doing there? Rocco. I'm Tim. I apologize. PT South Africa. Amazing. Cool. Well, this is our airway adjunct table, but Skyler can't use an airway adjunct, so you can aspirate and then an airway adjunct. Nasal cannulation breather. You guys want to do like a 2-minute demo on any of these, and then we'll all give you feedback on your demo. Sound good? Who wants to go first? First person gets to pick. You might get stuck at the end with fecal management system if you don't.
People management, I like that.
No FMS. Fresh out. BEC is discontinued FMS is that. Absolutely, that sounds great.
So we're going to be teaching NCLA or nasal airway. Thoughts on whether you need this or yeah. So this is part of our airway assessment. If there's concern for an obstruction, this can help relieve an obstruction. So if their tongue is flopping back and blocking things, or there's vomit, and we want to make sure there's so in terms of indications, that's when we're using it. Any thoughts on when we might not want to use it or what things we might be worried about? Exactly. So we don't want to put more damage, but then just say something like that. All right. First thing you want to do is you want to measure. So you want to take a look at the patient and you want to measure from the ear. I'm going to use my lovely model here. I always get confused with the
Nair to ear.
Nair to ear. Yeah. Nair to ear. But this looks like roughly an appropriate size. You want to have lubricant and try to lubricate it if possible. And then the important thing is you want to do rectum parallel. So you want to go straight back across the floor of the nasal. Yes. Straight back to the nasal passageway. Yep. And then and so you can go ahead and practice if you want.
Great feedback for Sam. Part of that. That was excellent. Awesome. Who wants to go next? This table is thrilling, I know. And pretend it's an arm breathing out of that shirt. Oh my
All right, guys, you have 5 minutes remaining. 5 minutes remaining.
Feedback for JP. That was good. You guys did great together. Let's talk about not discharging patients from medication. Yep, exactly. Yeah, the priorities were well, great work. I think you guys have about 2 minutes before your next session in B. 1 minute. You want to grab a sip? 1 minute. Thank you, Rama. Keeping me on target here. She's on it. I'm going to get a refresher of water. You guys' group is amazing. Got a really good dynamic. We bonded. That's the best part of this workshop. It's fun. It is fun. It's fun. Bring in the jokes. Clinical acumen. You guys got it all. We have it all. Right.
All right, guys, time is up. Please continue to rotate. Again, time is up. Wrap up your talks and continue on.
5-minute warning. All right, it's time to switch. Time to switch tables. 5-minute warning. Time to switch stations. Time to switch stations. 5-minute warning. All right, that wraps up our procedural skills stations. If you can make your way to your seats. Thank you. Okay, so let's get ready for our next lecture. If I can ask Dr. Shama Patel to take the stage one more time. She will be discussing course logistics, overview of IFEM and AFEM regulations.
That's exactly what I'm going to say, because it's exactly what it is.
Let's hear what you have to say.
All right, we good? Anybody need a break? I hear no. Oh, Niece needs a break. Oh, you cleaned it up. That was so nice. Thank you. Where am I going? I'm doing logistics, right? All right, I'm just getting there. Sorry. No, all good. All right, course logistics. I've done the logistics for many, many courses. There's a lot more tools than there were in 2017, 2018 when we're starting this out. We have equipment lists, we have ratios, all this stuff. None of it ever goes to plan, ever. So you want a sponsoring agency. I'll give my comments later. You want a sponsoring agency. You always want to be invited in country. Ideally, Ministry of Health, could be an institution, could be a medical school. Less so, you want the regional societies or any international societies to be the ones leading them in country. There is a standards and certification process. Yeah, there's not. For like 4 years, it was me in an email. So this is what it is. This is very, don't even get in the weeds of this. Do your BEC, do it the right way, be sponsored, do it because the people need it, and kind of forget about this part of it while you're trying to plan, and it can happen. Joy knows, she probably emailed me 700 times. Yeah. So that's not why we're doing this, to get some sort of accreditation from an outside institution. We're doing this to teach people and move emergency care throughout the world, right? To bring it to the people that need it. I didn't wear my glasses, I can't see that far. Right, so adherence to the 100% attendance, this is actually a problem in a lot of places because, you'll have coffee break, you'll have lunch break. This is a big thing, never talk over coffee or lunch. These are required breaks in many countries, right? You need 2 coffee breaks, like in Kenya, right, Travis? 2 coffee breaks and lunch. You never cut those short, ever, because it would be mutiny. A lot of these people are actually getting paid to come or forced to come, so they may try to dip out early. So usually we do morning session, afternoon session sign-ins. You feel like policing adults, but you have to do it because a lot of people leave, and it just helps people accountable. Yeah, so the printing and distribution of manuals, I told a couple of groups this, I think. Don't assume that you can print in country. It's expensive, it's difficult. Bring them with you. You can also negotiate with airlines, FYI, if you're going for, like, I hate this word, and I will never say it again, mission work, no. But a global health experience, whatever you want to call but not mission. And so they'll give you like discounts and let you transport the stuff. So I've had that happen where they don't like charge you if you don't have the money. Venue, catering, printing, equipment. So sometimes your host institution will allow it. Sometimes you'll have to have funding to do it. You'll have sponsorship, whatever the case may be. The whole goal of BEC is to get it where it's kind of like how Nisi and Joy and Belize have done it, where now it's just its own machine. Like in Ethiopia, it's its own machine now, so that you're not needing external people to come in and teach it, because that's expensive. And if you want people to teach, regionally there's a lot of people. So like if you're working in Africa, there's a lot of African trainers. Asia has some. Latin America has a lot more now. So that's another good thing. Yeah, print everything that you can before you get there. And people want a physical copy. So don't think that that you can just do it electronically, kind of how we do things here now. They're gonna want a physical copy. Okay, so securing confidential data generated. This is actually confidential data. It belongs to the country. It should never leave the country. So if you need to de-identify it, track it however you want, but that material, anything with any identifiers, does not leave the country. All right, so venue booking, AV equipment. So assume that you do not have electricity, you do not have power. Always think like that, because then you won't be left in the lurch when things go out, like you have a storm, whatever happens. Somebody hits a power line. Make sure that the venue's set up for small skills. A lot of people are used to this formal, I'm talking to you, and you're listening. We want this to be more engaging as a reflection of EM in general, which is a team sport, right? And so a lot of people need to change their mindset and evolve their mindset into that. Transport directions to venues. Nothing ever starts on time, nothing ever ends on time. You guys know this is not rocket science. There's suggested BEC and TOT schedules. There's ones for 4 days, 5 days, 6 days. People do it all sorts. Like Sudanese colleagues, they do it once a week for a set series, and they don't even do the full day, they do a couple hours. So it just depends on when you can get people. Special scheduling requirements, this is also important. Are there prayer times? Are there other things culturally and locally that need to be addressed? Also know holidays, know the country holidays, because that's kind of screwed me a little bit, especially when I first started working in Ethiopia, because they have 17 million holidays, and so you just have to know. Review schedule and focal point. This should all be done prior to going. Distribute the schedule, and then the catering must be arranged. Again, see how catering is mentioned multiple times? It's a very important part of this. I cannot reiterate that enough. All right, so this is suggested as 5 days. I mean, you heard Joy earlier, you gotta work with the people to figure out what's the best case. It might be an hour lunch once a week. It's just getting the information out there in whatever way can be done. Because most of these people have, again, 18 jobs, and so this is taking them away from something else that's equally as important, or if not more important. And then BEC TOT 1 to 2 days, you can do this quicker depending on who your audience is. And because these are the ones that are doing the TOT are the ones you picked out that are super engaged, so they're gonna take it upon themselves also to do a lot of the work. So this is one of the schedule. This has been there since 18. It's the same schedule. Yeah, whatever. Make a schedule as you go. Yeah, this is the same one. So I don't like this, where it's you just do a bunch of lectures, and then you start doing skills. I find the best way to do it is do a lecture and then do that skill station, do those scenarios, because it reiterates people. So that's why I think it's funny that we're still using this, because I don't think anybody does it like this. This is a 7-day BEC TOT. Really, you just need to cover the material. Whichever way you and your partners decide to do it, it's fine. Oh, and earlier I said that you can modify slides, so you can't take anything away. Everything in a BEC has to be taught, you can add. So you can add video, you can add sound, you can add other stuff. It's just you have to make sure you teach all of it. Make sure, I think I told every group this, that you bring all equipment that would be needed to be taught. Don't expect to use anything in country, especially because it might be the only equipment of that nature that they have, and they have to actually have it in the hospital or wherever you are. Ideal equipment plus improvised. There's been many videos, actually, if you just YouTube it. Sudan did it, a bunch of other countries did it, where they show low fidelity SIM and local use of materials. So have people give that input, and it really engages people to tell you how they do this. Like, this is how we make a call, this is how we do this, you know? And then some medical supplies can't be improvised, like the BVM. So again, this is also used as an advocacy tool for our colleagues to go back to their administrators and be like, hey, at BASIC, we need this thing because it will save someone's life. The whole point of BEC is life-saving interventions for common ER things. Did I miss anything? Yeah. Oh yeah, we have checklists. There's many checklists. So manual, again, print. Administrative documents, remember to print all that stuff too. So sign-in sheets, morning and afternoon, all that stuff should be printed before you go. And we have lists. If you don't find them, you can always email me. I will get back to you at some point. I'm better at it now than I used to be, but still not great. Certificates. All right, is this me too? All right, keep talking. Cool. What is this? Oh, this is the logistic planner. Oh, I helped do this one, yeah. It's just all the things that you need. I'm not going to read it to you. And it should have everything. It's been checked and rechecked and double-checked and got triple-checked, so it should have everything that you base on the basic parts need. Again, catering. It's a big section. Morning tea, lunch, afternoon tea, bottled water. Prayer time. It's an important part. And then the venue and transport. Don't forget transport too, because sometimes the host organization may book the venue, may book the food, but won't book the transport. So just make sure people have that. I've noted that before every group, anybody who's going to be in it, like create a WhatsApp group or Telegram, whichever is more used in that location. And then if you don't have a mannequin, we've talked about it in our BVM section, Nisi and I, use each other, use boxes. There's many things. Like you can use boxes for tension pneumothorax. Like there's all these different tricks that people have learned over the years and that our colleagues use daily. Again, printing, attendance, certificates. So data capturing, just so you know, these are the things that are required with BEC. Obviously the name of patients, pre and post test. The workbook check, so they should be filling out all of those workbook questions, case scenarios and stuff as we go. Skills check, which is kind of done towards the end. Case scenario, I said that. And then all hard copies to remain, again, which I say, at MOH or whichever, if it's the local emergency medicine organization, the country organization, but it never leaves the country. You never take these documents with anything about that. Like you can de-identify it and put it into a spreadsheet, but you don't take the actual documents. Yeah, so participation list as soon as possible, sponsoring list, all that stuff is important. So again, this is the equipment checklist. It should have everything, and some probably extra stuff, but like stuff like you'll forget is like scissors or like staplers or pens, things that you think are easy to get, but probably are not gonna be easy to get. And then I think I said this to everybody too, but also know your, our hospital in the US, they're the supply people because they'll give you all their expired stuff. And you can bring it to country to use, so you're not using any materials that actually can be used on a patient. Why do I keep walking over here? I can't see anything. All right. The printing checklist. So yeah, I developed this because people are having so many problems figuring out what to bring to print. This should have everything. Make sure you have extra, because people will show up. Because the ministry, if you're sponsored by the ministry, a lot of times they'll be like, oh, hey, this person needs to come, and then you just have to make room for them, and that's just what it is. A daily faculty meeting checklist. Well, that's nice. So this will kind of tell you anything at the end. So how I've done it, in the morning, we have like a pre-meeting with the facilitators, and at the end, we have a debrief. I don't know how, Travis, Joy, is that kind of how you guys do it? And I think it seems to work well to kind of just deal with any issues, anything that anybody's having problems, to kind of help them through. I did say that no one fails BEC. It's 99.9% true. If people are struggling, the whole point is not to be punitive. This is all about learning, so we want them, so just take the extra time, call it remediation, call it whatever you want, but we want everybody to leave with the skills. This is not about leaving people behind. Oh, am I done? Yes. Any questions, guys? What's up? They never do. I don't know. I mean, like towards the end, I think I started doing, because I started doing it every morning. I think it depends on the country and how and who they are. Because if these are people that are higher level, have multiple jobs, they're not going to necessarily do it. They're going to do it as we go. Because there's also vocabulary words in it and all that stuff. So it just depends, I think, on your population. That's a good idea. That you need to. Yeah, but again, it's not punitive. You know, just be like, oh, hey, you didn't do it today, so can we get it done for tomorrow, kind of thing. Other questions? I mean, most of these logistical lists, checklists, are pretty run through and just should cover, I would say, like 95% of what could be needed. But there's always going to be a 5% of just, I don't know, we lost everything and we're going to do it on the floor and, you know, some hut, and that's going to be it. So it'll just depend logistic-wise, but there's a lot of BECs that have been done, a lot of people that are here to help anybody who wants to do this. Any questions, concerns? You want me to shut up because I can?
Thank you, Dr. Patel. Thank you, Shama. All right, so we're going to take a quick break. Just a couple minutes, like 5 minutes, just to regroup, and then we'll power through these last couple of lectures. It's probably going to take another like 30 to 45 minutes, and then we'll have a post-test. So go ahead and take your break.
So nervous, I left my phone here. Oh. Thank you.
Okay, everybody, let's regroup. I'm going to call upon Dr. Yanissi one more time. All right, guys, let's focus as we have just a couple more lectures to go. That's it.
2 more.
End game. Dr. Yanissi, do you mind coming up? Thank you so much. You all know Dr. Yanissi. She's going to be talking to us about some of the resources. So the rest of the lecture is really just logistics and resources for both you, the healthcare system, as well as your learners.
Hello? Okay. So, do you guys have any questions up to now before we continue with the other resources? Do you feel that you can organize a BEC course and go there and teach it from start to finish for 4 days or 7 days or 5 days? No questions? I'm going to group you and put you to teach in Belize once a month, like this, June, July, August. If you're ready, we're going to do that. So we've spoken about the resources that we have, and it has been difficult to move for BEC for the rest of the world. One, because language is a big barrier. This QR code takes you to the manual and slides on the WHO page, and you can access them. They were actually updated October last year, so they're updated slides over there, and there's also conflict-related PowerPoint slides that you can do, and you can use it to teach if you're in an area or if you're teaching somewhere that they might need that. The manual has been translated to Spanish a long time ago. However, the slides were not translated to Spanish until last year, but they're already in Spanish. And we're trying to get other languages, like she said, they're trying to translate it. It does take a lot of time to translate. For example, for Spanish, it was difficult because whatever I was saying in Spanish, in Mexico, they understood it correctly, but if you spoke to someone from Argentina, they're like, that does not mean that. So Spanish was very varied. So when we're translating medical knowledge into that is very complicated. So this link takes you to that. And there's, yes? All right. There's also an app, and in Belize, so I don't know, it depends where you're going to be working at. In Belize, it worked for some time, and then we weren't able to access it because of the different things that they blocked us out from. So it depends where you're working. You have to check if the app works for the specific country that you're teaching at, but the app is there. And it gives you a good summary of all the skills that you can have. It has pictures. It has all of these summaries that you can use, that your audience can use to review material. This one, it's a link. It has a password. And it gives you clinical cases. So we were doing case discussions, and the book actually has 2 or 3 cases per module that we can discuss. However, this one has about 6 to 7 clinical cases for each module. So it gives you step by step, and it asks you question. Okay, in A, what are you going to do? And you have to click the correct answer, and then it moves you along. And it gives you a good way to follow up for your audience to be engaged into doing clinical cases. So if you have someone that has been having difficulty getting the ABCD approach, these ones are very good for you to get them into that A, then we do B, and if you don't do B, you go back to A, and so forth. So I read half of them this week, and they're like really good ones that have been added to them. The videos, when we're looking at skills and we saw the skill stations, you saw that some of the skills, we had resources here. But if you're teaching in scenarios where you don't have resources, you have to use your imagination. And sometimes showing videos, it's easier. Technology has brought us very far. So even if you're just showing it on your cell phone or an iPad or on your computer, you can download them and have them there so that you can show them. And sometimes it's easier for people to learn if they're looking at a video than if you're explaining something. Not everyone is as good as my friend here, Farah explaining how to do a BVM and being so enthusiastic about it when she's teaching it, because not all of us can teach. Not all of us are able to teach a skill in a fun way that is going to make everyone learn it. So everyone learns differently, and sometimes a video can help them to review afterwards. So this is a set of videos for all the skills that you have there that they have done. And then there is this mentorship program that you can create for whatever area you're teaching at. And it's not just for your participants. When you guys go out there and teach and you're doing a logistics planning, if you don't know, Shama said catering is important. It is important because you can motivate them to do a skill, and then you're like, there's coffee back there. If you don't do the skill, you're not getting coffee. You can use it as that. But you can also call us and let us know, hey, I'm having trouble. I don't know how to teach how to do a needle decompression. How can you do it? I don't have this material. How can I improvise? We have improvised in so many ways that you have no idea when you're trying to get stuff and you're just using the same ambu bag or the BVM to do a uterus and to do a uterine massage using that bag and putting cotton in it for it to have. So all of us have ways of improvising, of finding how to do it. And if you can create a mentorship program for all your audience and keep that line open, because they don't do this every single day like us, they will have questions. So if you keep that open, they will come back to you and they will ask, I have trouble with this. And go back to them every month or so. Or if they are working in your environment, well, in my case, they work with me at the hospital, so I get to teach them and to question them and to reiterate all the material that we have covered in BEC. So if you can create that sort of program that within their working environment, they are implementing BEC, and Shama is going to talk about all the logistics about how the whole picture is for emergency care and how we're rolling it out as a worldwide program, you're going to understand that BEC is just a little piece of it that we're trying to do. So doing this, talking to them, set up your local champions, find who they are. There are a lot of them that want to create these programs to make it sustainable. And if you make it sustainable, after a while, you won't be needed. They will continue doing it on their own, and you might just go back and be proud that you created something or you helped create something that is sustainable. So that's the main thing that we're doing here. Any questions? None? Shama?
We love you guys. It's just, I don't like my sound of my own voice anyway. All right. Hello? Okay. So I think this is probably really important to know that BEC is part of a giant initiative that's been going on more than a decade with WHO. It's gained a lot of traction, a lot of money to roll out emergency care at all countries at all levels. So this is actually, I think, an older one. There's more tools than this. But initially, the emergency care toolkit that a lot of us have implemented started off with BEC, an integrated interagency triage tool, which is used the color system, red, orange, green, yellow, orange, green, red, orange, yellow, green, sorry. The resuscitation area designations, this is kind of an area in the ER that's used for very sick, like ESI1 or red patients. Emergency care checklists, these are for medical and for trauma. One page, a lot of places put it as a checklist to just be like, hey, these are quick things you need to check to make sure. And then standardized clinical forms. This has been a project of many people to roll this out and to create databases. There's a trauma database that's being used to track trauma throughout the world in certain countries. It's still a work in progress. So these are some of the other tools. They're always developing new ones. So the emergency system framework, which we'll show a picture in a second, but a lot of countries that have, if they have nascent or no emergency care, they start off with an EXA, which is an emergency care system assessment. So you're looking countrywide, like macro level, what resources do we have? Do we have any emergency departments? Do we have any emergency units? Who's providing that care? At what level? What medicines are there? What equipment's there? That kind of thing. And then the clinical care guidance, which is the basic emergency care, community first aid. So that's been done. I think basic ambulance provider course. They have one now for EM leadership, running an EM department, other ones. Then process guidance, essential resources for emergency care. So I talked to a lot of you know this, that WHO as a whole, each country is supposed to have or required to have a certain amount of essential medicines that are listed. Countries are supposed to, not every country does, not every location does. There's an equivalent one for essential emergency medicines and equipment. The trauma registry and emergency care registry, which is being integrated into DHIS too, and then the trauma care resources. So I know a lot of you know this, in 2019 it was a really big deal, a lot of people worked on it. Emergency care was part of the World Health Assembly and was approved, so all member countries are responsible to take up these tasks, which is why WHO has all these tools. COVID kind of, did what COVID did. This is the framework, so, we're all in EM, so we know scene, transport facility. It's this initiative, framework, whatever we were calling it, it covers all of that, and so they started kind of at the basic level, right? That's why they started with BEC, it's kind of the scene level at the basis, and then they're working with EMS, ambulance, facility, doing disaster, all that stuff, incident command. It's all consensus. Like BEC is ICRC, International Committee for Red Cross, and WHO. It's consensus-based and designed for all levels. All right, so I'm just gonna, okay. So this is pretty exhaustive, I would think. There's still more tools always being in development. So this legislative toolkit is really good for our colleagues who are recent, like EM has become recently in a specialty in their country or is in the process of becoming a specialty in the country to use as an advocacy tool. Checklist, care, and then the clinical forms is integrated. For those of you who don't know, DHSI2 is ministry level data collection for health. And then standard and protocols for pre-hospital. So emergency care toolkit, you guys can look at all this. There's presentations attached to all this and explaining this toolkit. So part of BEC, if that's how you get your foot in the door to a location, to a country, to an area or hospital, is one step in getting them to think about all this other stuff. So this is all about getting people to understand that emergency care, which we all know is the most important specialty, bar none. It is, come on now, we know. Cardiologists can do our job? No. So, I'm just saying. So we need to prove this to people, right? People don't realize that, what we do. My mom, when I became a doctor, was like, why did you become a doctor? An Indian mom said this, no joke. And then she's like, why aren't you like an ology, like a cardiology, what is this, emergency medicine? She still doesn't know. Accepted the fact that she just never know. What she said to me the other day? She's like, you just sit at your computer and type. I was like, oh, hell no. No. I'm not even talking to you anymore. I was like, no, those 40 patients in charts I had to do, no. All right, sorry. Cathartic therapy there for a minute. So then the trauma registry, again, open access. Just reiterating, don't worry about other things, it's open access. Again, make sure you teach the full course. The whole point of why the accreditation, all that stuff happened is because we want people to stay true to the course and because it was consensus driven throughout the world, right? So multiple people from multiple regions vetted this for years. So don't take anything away, but definitely add adjuncts, especially with interactive stuff, videos, anything that can get people to internalize this information. Again, this is a triage tool, and it's used, anybody who's worked internationally, this is what we use for triage. the color system. And you know what? It's as imperfect as our triage. So there you go. Yeah, so this is a checklist. Places have put it up. It just has really key things like, oh, this person has tension pneumothorax. Did you needle decompress? Just to remind people if they don't see this stuff every day. And then there's a stationary we talked about. This is another advocacy tool to be like, hey, we just want these basic things to save people's lives. Standard forms, these have been adopted. So we tried to implement this in Ethiopia, and they're still trying, but there's a lot of issues on like what to include, what not to include, like do you include ethnicity, do you include like, so it becomes a bit more complicated to implement this, but it still gives you the basic information, and it helps people when they're transferring patients to think methodically in an emergency medicine, ABCD kind of way. Resources for emergency care, the bag. So we all have our own things that we take that make us comfortable when we need to respond. So there is a list. It can be adopted, but it's been vetted. So all this stuff has been vetted from multiple countries, from multiple providers at different levels. So it's pretty comprehensive, but always room for improvement. The International Trauma Registry is up and running. They're putting out data. It really is, because there's a whole trauma initiative. GECI, I forgot the acronym. They love their acronyms. And so it is supposed to track to give us a better idea of the traumas that are being seen. Trauma care resources, so these all exist at different levels, so pre-hospital, guidelines for improving trauma quality, all that kind of stuff. Supporting those affected by road traffic. I haven't seen, no. Yeah. All right, questions. Okay, I'm gonna stop here, obviously, because this has questions. But so also know that like you can add on things. I didn't realize this when I first started, like Stop the Bleed is a good adjunct to this, right? Stop the Bleed is free, it's open access. When we talk about hemorrhage and trauma, it's good to kind of include some of that stuff that's already been vetted and peer reviewed and validated as part of this. So you can incorporate that. Like, I think you guys in Pakistan, are you the ones that did the disaster stuff on top of it, like incident command and stuff? There's one group, I forgot who it is, over there. You guys did. No, you're asking, why are you asking a question?
No, I'm going to add that for the local protocols. For example, with us, we did for maternal health. So they had one for PPH, and we included the PPH training from the Ministry of Health. We included it in the BEC. So depending on what they have locally, if you can talk to them, you can also include it in whatever you're doing, depending on what their needs are. No.
So we were talking earlier. So, you know, we talk about CPR, ACLS, like these are terms that we use. It's the US-based system of kind of lay responder, first responder type of stuff. Not every country does it, and not every country you should do it. There's a lot of debate about like, should you be doing ACLS in a country that doesn't have definitive care, all this stuff. So just know those local things. So just don't, you know, when you first do this, and I still catch myself doing this, teaching other things, is that I'll be like, oh, just ACLS or CPR, because you're so used to it, especially if you've been like actively practicing in the US. And you should remember that that's not necessarily the case in a lot of countries, and people will ask you, why isn't CPR and ACLS in this course? Know what the protocols are in the country and why or why not is not included. Because it may be that like there is a definitive care, and so resuscitating somebody or doing CPR on somebody that you can't do a cath on, then there's all ethical issues about that. Those are my big things. Any questions on the tools? They're on the website. If you just go to WHO, if you just Google WHO emergency care, you'll see all the tools that are available.
Thank you, Shama. So just a couple of announcements and then a couple of acknowledgements is between you and the post-test and Freedom. So without further ado, I wanted to just make an announcement that, as many of you have seen, we have been walking around taking pictures for like promotional and also for our own memories. If you prefer not to be pictured, just come talk to me, and I'll make sure that any pictures that have you in it are deleted. So.
Just to piggyback that, and every country is going to want pictures, make sure there's like a waiver that's part of this too. Like make sure people sign a waiver that they're okay with that, and if they're not,
Yeah. Pictures can be a great tool, both, like I said, for promotional and for people to understand better whenever you come back to the States, or also within what the impact is. A picture is worth 1,000 words, as you guys know, but it also can be very damaging if you're not respectful to the local culture, and make sure that you don't get consent, because we are working with our peers. So making sure that everybody knows and is aware that they're being photographed, and then making sure that they also know that they can defer or have those pictures deleted. So come talk to me if you have any issues with that. I'm happy to make that happen. The other thing I wanted to talk about was certificates. So after this, you will be receiving a certificate. Did we print them? Okay, yeah. This is a last-minute logistical thing, but we do have them printed out. So once we get your test in and make sure that you have a passing score, then you will get a certificate. So just come see us up here after you're done. That's number 2. And then I would like to make a couple of acknowledgements, thank yous. So Penn Medicine Clinical Simulation donated a lot of the supplies that you see here. Pro Sports EMS gave us the mannequins. So thank you so much to them for providing us the materials that we needed to do this simulation. Yes, feel free to applaud. I don't think they're here, but we're applauding to them anyways. Also, I wanted to say that this has been a really great experience for me personally, as well as the team. But as you guys will see, leading a BEC is a team sport. You need everybody in the team for sure. And everybody has strengths and skills that they bring to the table. So I just wanted to thank my team who's sitting in the back, and I'll acknowledge them one by one. So I have Dr. Joy Mackey, as you guys know, is from Baylor. She is one of the facilitators. She brings with her a wealth of knowledge and experience. And she also was vital in gathering participants, getting the word out, and also other facilitators. And she is one of the reasons that Dr. Nissi is here from Belize. So thank you so much, Dr. Joy Mackey. As I'm calling you out, if you want to stand, feel free. If not, it's up to you. And then I have Dr. Sean Boaglio. He's from Vanderbilt University, and he does teaching in Guyana. Do you mind standing? This is Sean. He was amazing in basically taking care of all participants, putting you in groups, making sure you got your materials ready, making sure that everything was okay in the background as far as participants, getting you guys signed in. So he was a huge help. Thank you so much, Sean. And then Dr. Travis Wayland, he's with EPPA. He was wonderful in stepping in. He's also a wonderful facilitator, but he did us a great service by jumping in and being the coordinator for the facilitation of this course. And so along with that, I wanted to acknowledge Dr. Nichole Michaeli. I'm sure many of you know her. She is a fellow at Brigham, and she leaded us off in that. And she did an amazing job in gathering facilitators and making sure they're all on the same page. So thank you so much to her, even though she can't be here today. Dr. Patel, Shama Patel, or Shama, as she prefers to be called, she jumped in at the last minute to cover so many different things. And as you can see, she's a natural and she knows this stuff like the back of her hand. So we're really grateful that she came here and was able to help us today. Next is Rama Memon. I said your name wrong again, didn't I? Can you say your name right?
Rama Memon.
Memon look like lemon. Okay. This is embarrassing. Sorry. So I wanted to thank her. She's done a really amazing job with like timekeeping and just being like my right-hand woman. And any last-minute thing, she's been extremely helpful. She's going to be a Global Health Fellow at Penn next year, so definitely somebody to keep up with. She's a rock star. And then I want to thank Dr. Yanisi Cruz from Belize. She traveled from so far away, like we talked about earlier, and we're just so grateful that she came to teach this. And she's a wonderful lecturer, as you all saw. Dr. Amanda Irish, she's also here today. She stepped in to be a wonderful facilitator and teach some of the small groups. And along with Dr. Sally Graglia from the University of California, UCSF. Also a wonderful facilitator. Tim Depp, Dr. Tim Depp, are you here? Awesome. Yeah, he was great. I also wanted to acknowledge some of the residents who came here today. So Lee Klosner, are you here? Hi. So she was fundamental in some of the advertising. She's really good with graphics, and so some of the graphics you may have seen online, she's the mastermind behind that. So thank you so much. And then Hallie Alberts, she pretty much took the lead on the certificates. So all the certificates, if they're messed up, it's her fault. I take no credibility. I'm just kidding. Thank you so much for doing that. Also wanted to acknowledge, I hope that's everybody in the room. Oh, Mary. Sorry, last but not least. Mary came all the way from Kenya to be a facilitator here. Thank you so much. We loved having you here, and it was a great experience working with you. And I hope that we get to work with you in the future in Kenya and elsewhere. Also, thank you. And then also Kimonia. Kimonia is a medical graduate in Nigeria, and she has been doing a lot of the behind the scenes, like taking notes and finding different people, sponsors or facilitators. So she's been doing a lot of work behind the scenes. Along with that, like I said, Dr. Nichole Michaeli, who couldn't be here today, and then Dr. Naz Karim, who was the past GEMA president, works at Brown University. She has been fundamental for this course. She wasn't able to make it, but she pretty much got this whole thing going. So we're really grateful to her. I hope I haven't missed anybody. Oh, our MSAs. Our MSAs were awesome. Thank you so much. So we have Jordan in the back. And this is Matt, and we had Selma for a little bit as well. So thank you to the whole team for helping put this all together. I hope that this was a worthwhile experience for you. I know this was a whole day, and you guys put some money and effort into this, so we really appreciate you being here as well to make this happen. And please feel free to reach out to any of us if you have any further questions or would like to get on board with some projects. That's what we're here for. That's what these days are for. So without further ado, I think we should go ahead and take the test so you all can relax. But then afterwards, I do ask that we stay for one more picture together as a group, and then you'll be free. So here are the QR codes. So the one on the left is for the post-test. The one on the right is for the survey. Please give us any feedback, what we could do better, what we did well, etc. Thank you so much.